Thank you, everybody. We're going to go ahead and get started. As we open and start with today's session on COVID-19 vaccines, I'm going to actually first turn it over to Dr. Melinda Wharton for an announcement.
Thank you, Dr. Lee. I wanted to call on our colleague from the Food and Drug Administration, Dr. Rebecca Rendell, for an announcement about some recent FDA regulatory action.
Hi, good morning, everyone. This is Becca Reindell. This morning, the FDA authorized the Novavax COVID-19 vaccine adjuvanted for use under EUA as a first booster dose to individuals 18 years of age and older, for whom an FDA-authorized mRNA bivalent COVID-19 booster vaccine is not accessible or clinically appropriate, and to individuals 18 years of age and older who elect to receive the Novavax COVID-19 vaccine adjuvanted because they would otherwise not receive a booster dose of COVID-19 vaccine. For these individuals, a booster dose may be administered at least 6 months after completion of a primary vaccination with an authorized or approved COVID-19 vaccine.
Thank you. Dr. Twentyman?
Thank you so much. As a further update, Centers for Disease Control and Prevention has signed off on recommending use of the Novavax monovalent COVID-19 vaccine as a single booster dose in those ages 18 and above, as outlined in the authorization from the Food and Drug Administration.
Sorry, I'm trying to struggle because I have switched to my phone.
Following these recommendations, you will see our interim clinical considerations for use of authorized and approved COVID-19 vaccines updated, along with all accompanying schedules and clinical guidance materials. Thanks very much. Over to you, Dr. Daly.
Okay, Matt Daly here. I'm just waiting for my slides to come up. Okay, great. Thanks so much. So I'm going to be introducing this afternoon's session on behalf of the ACIP COVID-19 vaccines work group. I'm going to pause for a sec because looks like the slides just disappeared again. Okay, great. Next slide, please. To provide several updates to start with, bivalent booster authorizations have been extended down to children ages 5 years and over. So on October 12th of 2022, the FDA granted emergency use authorization for the use of Moderna bivalent COVID-19 vaccine boosters in children ages 6 through 17 years. On that same day, there was also emergency use authorization for the use of Pfizer-BioNTech bivalent COVID-19 vaccine boosters in children ages 5 through 11 years of age. And then on that same day, the CDC signed off on those recommendations and endorsed those for the exact same groups and ages. Next slide, please. So, excuse me, to review COVID-19 vaccines workgroup activities for the months of September and October of 2022, we have reviewed and discussed the vaccine safety and immunogenicity data for monovalent Moderna COVID-19 vaccine boosters for children ages 6 through 17 years of age. We also reviewed vaccine safety and immunogenicity data for the Novavax COVID-19 vaccine booster for adults ages 18 and over. In addition, we reviewed and discussed COVID-19 epidemiology and outcomes among people who are pregnant, as well as COVID-19 epidemiology and outcomes among infants. In addition, we looked at vaccine safety and effectiveness data pertaining to the use of COVID-19 vaccines during pregnancy. And then we also discussed the proposed integration of COVID-19 vaccines into the Vaccines for Children, or VFC, program. Next slide, please. So the agenda for this session this afternoon is as follows. First, we'll hear from Dr. Ellington at the CDC, who's going to review COVID-19 in pregnant people and infants ages 0 to 5 months. We'll then hear data regarding vaccine safety during pregnancy from both Dr. Olson at the CDC and Dr. Carbonda from Health Partners. We will hear about the effectiveness of maternal COVID-19 vaccination in pregnant people and infants from Dr. Fleming Dutra from the CDC. Following that, we'll hear from Dr. Oliver at the CDC, who will review a summary of the evidence around COVID-19 vaccine use in children. And then we will hear from Dr. Santoli, who will review the implications for the Vaccines for Children program. There will then be public comment, following which there will be a COVID-19 vote that is specific to the inclusion of COVID-19 vaccines in the VFC program. Next slide, please. And then I'd like to thank the ACIP COVID-19 vaccines work group, including ACIP members, ex officio and government members, liaisons, consultants, and the excellent CDC leadership of Dr. Oliver and Dr. Twentyman. Next slide, please. As well as a number of CDC participants in the COVID vaccine work. Back to you, Dr. Lee.
Thank you, Dr. Daly. We'll move on to the next presentation by Dr. Ellington from CDC.
If we could move to the next slide. And the next slide. So first I will provide a brief background on what we know about COVID-19 in pregnant people. Next slide. When we assess risks in pregnancy for new threats, we typically think about this in 3 ways. First, we assess if the state of being pregnant is associated with severe illness. For this, we typically compare pregnant people to a non-pregnant group, usually women of reproductive age. Second, we assess if pregnant people with COVID-19 have increased risk for maternal complications and adverse pregnancy outcomes compared to pregnant people without disease. And third, we assess if infants born to people with COVID-19 during pregnancy are at risk for severe outcomes. Next slide. A recent updated living systematic review and meta-analysis by colleagues in the UK assesses pregnancy as a risk factor for severe illness, so comparing people with COVID-19 by pregnancy status. Among all the outcomes examined, the odds of ICU admission and invasive ventilation were increased in pregnant people compared to non-pregnant women of reproductive age. An important consideration, though, is that the meta-analysis does not adjust for potential confounders, so likely underestimates the risks, as we have observed in our US data that pregnant women and people with COVID-19 are younger and have less underlying health conditions than non-pregnant people with COVID-19. Next slide. We closely monitored cases of COVID-19 in pregnancy using CDC's national case surveillance data, which includes a pregnancy variable from June 2020 to July of 2022. In this graph, the total cases are represented by the gray line. ICU admissions by month are in lighter blue, with deaths by month in dark blue. In total, 226,263 infections in pregnant people were reported as of July of this year. Case counts peaked in December of 2021 and January of 2022. There were 738 ICU admissions reported among pregnant people and 329 deaths. ICU admissions and deaths both peaked in August 2021 when Delta was the predominant variant. Next slide. So now I'm going to talk about the second and third questions to assess risks of maternal, fetal, and infant adverse outcomes among pregnant people with COVID-19 compared to those without COVID-19. These data are again from the same living systematic review and meta-analysis in the previous slide. All maternal and perinatal outcomes assessed were significantly higher in pregnant people. The odds of all-cause mortality was 6 times as high for pregnant people with COVID-19, and ICU admission was 5.4 times as high. There was a 57% increase in the odds of preterm birth and an 81% increase in the odds of stillbirth. Additionally, the odds of neonatal death and admission to the neonatal intensive care unit were more than twice as high for infants born to pregnant people with COVID-19 during pregnancy than those both to pregnant people without COVID-19. Next slide. These are data from the Surveillance for Emerging Threats to Mothers and Babies Network, assessing outcomes among pregnant people with COVID-19 during pregnancy. And this demonstrates that the risks also vary by trimester of infection, with the third trimester infections associated with the greatest risks of preterm birth, neonatal ICU admission, and infants being born small for gestational age. Next slide. So now I'll briefly present COVID-19 vaccination coverage among pregnant people and where we currently stand. Next slide. Here are COVID-19 vaccine coverage estimates in pregnancy from 2 data sources. The percentage that completed a primary series is in blue, and among those that received the primary series, the percentage that have received a monovalent booster is in green. The National Immunization Survey is self-reported survey data and this is data from the last month, estimating that 77% of pregnant people received a primary series. And of those receiving a primary series, 48% received a first booster. These data are weighted to be nationally representative. The second data source here is from Vaccine Safety Data Link, which uses electronic health data from 9 healthcare organizations, and found that 72% of pregnant people had received a primary series, with 60% of those receiving a booster. Overwhelmingly, most pregnant people received the primary series before they became pregnant. Also, the vaccine safety data, from there, you can calculate that 43% of pregnant people received both their primary series and their monovalent booster, indicating that more than half of the population of pregnant people are likely unvaccinated or undervaccinated currently. Next slide. Now I will pivot to talking about the epidemiology of COVID-19 among infants from birth up through 5 months. Next slide. This graph shows COVID-19 associated hospitalization rates from CDC's COVID-Net surveillance system in persons of all ages from the start of the pandemic in the US through September 10th, 2022. The shaded regions on the graph represent the different periods of SARS-CoV-2 variant predominance, from the Delta period to the Omicron BA.5 period. The focus here is on infants ages 0 through 5 months, shown in red, but other age groups are shown for comparison. Throughout the pandemic, rates in adults ages 65 years and older, shown in the blue dotted line, have been highest. And we know that older adults are at highest risk of severe disease with COVID-19. However, notice that in the Omicron periods, rates among infants ages 0 through 5 months have increased relative to other age groups. They have surpassed rates in those 50 to 64 years of age, shown in yellow, and they are now approaching the rates of those 65 years and older. Next slide. Here is a comparison of hospitalization burden for COVID-19 and influenza, which has long been recognized to cause severe respiratory disease in infants ages 0 through 5 months. During October 2020 to September 2021, the cumulative COVID-19 associated hospitalization rate shown in the black line was similar to influenza associated hospitalization rates during the pre-pandemic influenza seasons from 2017 through 2020, shown in gray. During October 2021 to April 2022, the preliminary cumulative COVID-19 associated hospitalization rate, shown in red, was higher than influenza-associated hospitalization rates during the same pre-pandemic influenza seasons. These data indicate that COVID-19 can cause a similar higher burden of hospitalization as influenza in infants ages 0 through 5 months. Next slide. Additionally, among infants ages 0 to 5 months with COVID-19 associated hospitalizations, 84% of infants had COVID-19 symptoms, including 97% of those greater than 1 month of age. 21% had an underlying health condition, with prematurity most frequent. 19% were admitted to the ICU. When we look at disparities in this age group, we see that the cumulative COVID-19 associated hospitalization rates are highest in infants ages 0 through 5 months who are non-Hispanic American Indian and Alaska Native, Hispanic, and non-Hispanic Black. As we know, COVID-19 has exposed long-standing inequities that have systematically undermined the health of racial and ethnic minority populations, putting them at higher risk for infection, severe illness, and death. Unfortunately, these disparities also affect infants. Tragically, COVID-19 has caused deaths among infants ages 0 through 5 months. According to death certificate data from January 2020 through October of 2022, 265 deaths due to COVID-19 have been reported, accounting for 0.5% of all deaths in this age group. Next slide. I'll now hand it over to Drs. Olson and Carbanda to talk about safety.
Thank you very much. This is Dr. Carbanda. I'm going to go first. And next slide. And next slide. So as an overview for this presentation from the Vaccine Safety Data Link, I will present analyses of spontaneous abortion case and ongoing pregnancy control surveillance following COVID-19 booster vaccination, and I will provide a summary of VSD studies on COVID-19 vaccine safety and pregnancy. Then Dr. Olson will present data from the VSafe COVID-19 Vaccine Pregnancy Registry, including describing the registry participant cohort and presenting preliminary data on pregnancy and infant outcomes. Next slide. This slide shows a map of the VSD sites with locations as of August 2022. 8 VSD sites contributed data for the analyses I am presenting. Next slide. For our case control surveillance, our primary objective was to conduct monthly surveillance of spontaneous abortion cases and ongoing pregnancy controls in order to estimate the odds ratio for receiving a third messenger RNA COVID-19 vaccine dose in the 28 days prior to the spontaneous abortion. Secondary objectives were to evaluate the odds ratios for receiving a third messenger RNA vaccine dose in a 42-day window and the odds of receiving any COVID-19 vaccine booster in a 28-day or 42-day window. Next slide. Booster doses were defined as COVID-19 vaccine doses administered at least 28 days after completion of the primary series. Primary analyses focused on a third messenger RNA COVID-19 vaccine dose after 2 prior messenger RNA COVID-19 vaccine doses, as this was the most common booster type in our population. Secondary analyses evaluated any booster type, with examples shown on the slide. These analyses preceded availability of the bivalent vaccine. Next slide. This figure shows our approach for the primary analyses. Using a validated algorithm, we identified spontaneous abortion 6 to 19 weeks gestation and assigned these cases to a 28-day surveillance period based on the pregnancy outcome date. We then looked for exposure to a third messenger RNA COVID-19 vaccine dose in a 28-day window prior to the spontaneous abortion. Next slide. Now we have added to the figure the ongoing pregnancy period controls. Ongoing pregnancies 6 to 19 weeks gestation identified using the same validated algorithm were assigned to 1 or more 28-day surveillance periods. Within a single 28-day surveillance period, we then assigned the midpoint as the index date and looked for vaccine exposures in a 28-day window prior to the index date. Next slide. For the primary analyses using generalized estimating equations, we then calculated the odds of exposure to a third messenger RNA COVID-19 vaccine dose in 28 days prior to spontaneous abortion compared to the odds of exposure to a third messenger RNA COVID-19 vaccine dose among ongoing pregnancies in the 28 days prior to an index date. This slide also adds secondary analyses applying a 42-day exposure window and changing the exposure to any COVID-19 vaccine booster. Next slide. In primary analyses, our population included 112,718 unique pregnancies from November 1st, 2021 through June 12th, 2022. Of these, 14,226 ended in a spontaneous abortion. Among ongoing pregnancies, 10.6% received a third messenger RNA COVID-19 vaccine dose before 20 weeks gestation, while 6% of pregnancies ending in a spontaneous abortion received a third messenger RNA COVID-19 vaccine dose while pregnant. Counts and breakdown by vaccine type are shown on this slide. Next slide. For our primary analyses, receiving a third messenger RNA vaccine dose in a 28-day window was not associated with spontaneous abortion. Adjusted odds ratios was 0.94 and 95% confidence interval was 0.86 to 1.03. Results were similar when stratified by vaccine type. Next slide. This slide now shows the adjusted odds ratios and 95% confidence intervals for our primary and secondary analyses. Adjusting the exposure window from 28 to 42 days or expanding the booster definition from a third messenger RNA vaccine dose to any COVID-19 vaccine booster dose did not substantially change our findings. Next slide. The analyses presented on spontaneous abortion and COVID-19 booster vaccines are part of a large portfolio of VSD work monitoring COVID-19 vaccine safety and pregnancy. The table on this slide offers an overview of the many ongoing VSD studies in this area and the status of this work. Some of these studies have been previously disseminated through presentation or publication. For others, the analyses are ongoing or we are waiting for infants to reach a critical age. We are currently evaluating safety of the primary vaccine series and the monovalent boosters. Along with spontaneous abortion, additional outcomes include stillbirth, fever and other local and systemic reactions, small for gestational age and preterm birth, pregnancy complications, major structural birth defects, and growth and developmental outcomes. Next slide. In summary, COVID-19 booster vaccination in early pregnancy was not associated with increased risk for spontaneous abortion. The Vaccine Safety Data Link is continuing comprehensive surveillance of COVID-19 vaccine safety and pregnancy. To date, no safety signals have been identified. Future studies will evaluate long-term outcomes and possibly the new bivalent vaccine. And next slide. I'd like to thank our large team who made this work possible, and I'll pass the baton to Dr. Olson.
Thank you. Next slide, please. Okay, thanks. So we'll now transition to discussing information from CDC's VSafe COVID-19 Vaccine Pregnancy Registry, which we last discussed during a previous ACIP meeting in fall of 2021. Let me start by briefly reviewing the enrollment and data collection process for the registry. Starting with the rectangular box on the left, people who voluntarily enrolled in CDC's VSafe After Vaccination Health Checker indicated they were pregnant at the time they received a vaccine, or if they became pregnant after vaccination at later check-in points. Individuals reporting a pregnancy were then called and screened for eligibility for the pregnancy registry. As shown in the middle box, eligibility was based on when they reported the pregnancy into VSafe, meeting the age criteria of being 18 years or older, whether they were an English or Spanish speaker, and whether they were either pregnant at the time of vaccination or were vaccinated in the periconceptional period, defined as the 30 days before the first day of the last menstrual period before the pregnancy. Eligible individuals were then consented for pregnancy registry enrollment and interviewed by phone at designated time periods over the course of their pregnancies, postpartum, and after the infant would have reached 3 months of age. Note that not all participants were interviewed during all trimesters of pregnancy, as they may have entered the registry at any point in this continuum, and some initial interviews were conducted after delivery had occurred. Participants were also asked if they would consent to obtain medical records for the pregnancy and infant up through 3 months of age. Pregnancy registry interviews began in January 2021 and were completed in August 2022. Medical record requests and reviews for select outcomes and conditions are still ongoing. Next slide, please. There were over 65,000 potential participants who reported a pregnancy into the VSafe After Vaccination Health Checker during the eligibility period. Attempts were made to reach all potential participants, with about 60% unreachable. Overall, 36% of potential participants were contacted and determined to be eligible for enrollment. Of these, 98% enrolled. In total, there are 22,953 participants enrolled. 15 participants contributed more than one eligible pregnancy. The distribution of vaccine type received is shown here and demonstrates that the majority of participants received one of the mRNA vaccines. This was due to the timing of the rollout of the vaccines and the lower uptake of Johnson & Johnson. The mean age of participants is 33.9 years. 45% reported they worked in healthcare, and 79% described themselves as non-Hispanic white. Next slide, please. Among registry participants, the timing of the COVID vaccine, which made the participant eligible for the registry, is reasonably distributed across all pregnancy time periods, shown here. About 10% of participants were vaccinated in the periconceptional period, about 28% were vaccinated in the first trimester, and about 2/3 of participants were vaccinated in the second or third trimesters. Next slide. These next two slides give an overview of outcomes for the completed registry cohort. Pregnancy outcomes are self-reported by registry participants with the exception of stillbirths. Self-reported stillbirths have been adjudicated and reclassified if needed based on medical records when these have been available. Overall, in this table, if you look across the rows at the bolded numbers, you can see that the proportions of live births and fetal losses were similar by vaccine type. At the bottom, the proportion of registry participants reporting stillbirth was 2.45 per 1,000 live and stillbirths, which is lower than the background rate from the U.S. National Vital Statistics System, where the stillbirth rate is 5.89 overall and 4.89 among the non-Hispanic white population, which again is most similar to our cohort. Next slide. Here we summarize the incidence of self-reported medical conditions, pregnancy complications, and infant outcomes by vaccine type. The column on the far right lists published incidence rates for comparison. Again, scanning across all outcomes and vaccine types, the incidence observed in the pregnancy registry was similar to or below available background rates. Next slide. For the sake of time, I'm going to skip the details on this slide as this analysis was presented at a previous ACIP meeting, where we reported no increased risk of spontaneous abortion or miscarriage before 20 weeks of gestation among the registry participants. Next slide. In an analysis of the first half of the registry cohort, major birth defects were reported for 429 or 3.5% of fetuses or infants. The purple bar is the overall prevalence of birth defects among all vaccine types received at any time during pregnancy. The red bar represents the prevalence of birth defects among those who received an mRNA vaccine during the first trimester. The blue is the prevalence among those who received an mRNA vaccine after 20 weeks gestation. There was no statistical difference between those vaccinated in the first trimester and those vaccinated later in pregnancy after 20 weeks. All of these prevalence estimates fall within the 3 to 5% expected prevalence for major birth defects, as is reported in the literature. Next slide, please. Finally, in an analysis of over 20,000 registry participants with pregnancies ending after 20 weeks of gestation, we compare the prevalence of multiple outcomes of interest, including stillbirth, preterm birth, gestational hypertension, NICU admission, and maternal ICU admission in the registry participants who reported no SARS-CoV-2 infection during pregnancy with those participants who reported SARS-CoV-2 infection after being fully vaccinated. Other studies have reported an increased risk of poor pregnancy outcomes among unvaccinated pregnant people infected with SARS-CoV-2. Although the pregnancy registry does not include an unvaccinated control group, as you can see from the prevalence ratios presented in bold on the right, infection after full vaccination was not associated with an increased risk of those outcomes compared to those who were vaccinated and had no reported SARS-CoV-2 infection. Next slide, please. In conclusion, the VSafe COVID-19 Vaccine Pregnancy Registry adds to the accumulating evidence on the safety of COVID-19 vaccination during pregnancy. To date, the pregnancy registry has not identified any concerning safety signals, including any increased risks of adverse pregnancy-related outcomes for either the registry participant or the infant, or any disproportionate outcomes by vaccine type or timing. Several findings reported today are from early analyses while data collection was ongoing. While all early analyses will be replicated with the final full cohort of registry participants, there's no reason to expect that associations would change over time. For select outcomes and conditions, the acquisition and abstraction of medical records is still in progress. This effort, which takes additional time and care, will aid in confirming and/or identifying conditions such as birth defects, where participant-reported information may have been insufficient in detail to make an accurate determination. Finally, CDC will continue to monitor the safety of COVID-19 vaccination during pregnancy with an extended follow-up through 15 months post-delivery or end of pregnancy. Follow-up calls are scheduled to begin in November. Next slide. I'd like to end by thanking the registry's participants for generously sharing their time and information with us, and the many people who support the registry, particularly our data team led by Dr. Andrea Sharma for their assistance in preparing this presentation. Next slide. Thank you.
Thank you very much, Drs. Ellington, Carbonda, and Olson.
Oh, sorry, there's one more presentation.
Oh, there's one more.
Yes.
Okay, let's keep going.
Sorry. Next slide. Great. So now we'll transition to talking about effectiveness of maternal COVID-19 vaccination among pregnant people and infants. And as a reminder, CDC recommends that everyone stay up to date with COVID-19 vaccination, including all primary series doses and the most recent booster dose recommended for them by CDC. And specifically, people ages 5 years and older are recommended to receive one updated bivalent mRNA booster dose. And staying up to date with COVID-19 vaccinations is recommended for everyone, including people who are pregnant, trying to get pregnant now, who might become pregnant in the future, and people who are breastfeeding. Next slide. This slide has been shown at ACIP previously and shows the difference in the composition of monovalent and bivalent mRNA vaccines using the 30 and 50 microgram doses as examples. Monovalent mRNA vaccines contain mRNA encoding the spike protein from the ancestral or original SARS-CoV-2 virus, whereas bivalent vaccines containing mRNA encoding the spike protein for both the ancestral strain and the Omicron BA.4/5 variants. Because bivalent vaccines were first recommended on September 1st of this year, there has not yet been time to assess effectiveness of bivalent boosters among pregnant people and infants, so the data I will show reflects monovalent vaccines. Next slide. We'll start with discussing monovalent mRNA vaccine effectiveness among pregnant people. Next. I believe you're all familiar with the VISION network, and the analysis I'm presenting today used a test-negative design to assess monovalent mRNA vaccine effectiveness against COVID-19 associated emergency department and urgent care visits and hospitalizations. Next slide. This graph shows monovalent vaccine effectiveness for emergency department and urgent care visits occurring among pregnant people and non-pregnant women. Let me orient you to this forest plot, which shows vaccine effectiveness among pregnant people in the top half, including those vaccinated either before or during pregnancy, and vaccine effectiveness among non-pregnant women ages 18 to 45 years in the bottom half. Delta vaccine effectiveness estimates are in the middle columns, and Omicron is on the right. All vaccine effectiveness estimates are then stratified by number of doses, with 2-dose estimates shown in green and 3-dose estimates in blue, and by days since last dose, shown in the parentheses after the number of doses at the beginning of each row. So looking at the Delta estimates, again in the middle, among pregnant people, vaccine effectiveness for emergency department and urgent care visits occurring during pregnancy was high at 78% or above for both 2 and 3 doses. Among non-pregnant women, we can see that the power is higher, as evidenced by narrower confidence intervals, but the vaccine effectiveness estimates and patterns are the same. Effectiveness was high, waned a little after 150 days after dose 2, and was restored by a 3rd dose. Now let's focus on Omicron, shown on the right side of the graph. And as we all know, the Omicron variant can evade monovalent vaccine-induced immunity more than prior variants did. And these estimates reflect mismatch between the monovalent vaccine and the Omicron variant. As expected, vaccine effectiveness for emergency department and urgent care visits is lower during Omicron predominance than it was during Delta. And among pregnant people, effectiveness waned to non-significant or not different than 0 by 150 days after dose 2, but was restored by a 3rd dose. We see similar patterns among non-pregnant women with waning over time after dose 2, restoration of effectiveness after a 3rd dose, but then waning again over time after dose 3. Next slide. This graph, which is set up the same way, now shows vaccine effectiveness against hospitalization. During Delta, again in the middle, vaccine effectiveness was very high, 98 to 99% among pregnant people, and 90% and above among non-pregnant women. During Omicron predominant, shown on the right, the study had more limited power due to lower numbers of hospitalizations. Among pregnant people, vaccine effectiveness at 7 to 119 days after dose 3 was 94%. Among non-pregnant people, vaccine effectiveness was 50 to 73%. Next slide. These data indicate that vaccine effectiveness of monovalent mRNA vaccines for COVID-19 associated emergency department and urgent care visits and hospitalizations is similar among pregnant people and non-pregnant women. I did not show these data, but in the published paper, vaccine effectiveness was also similar when stratified by doses given during pregnancy to that of doses given before or during pregnancy. Thus, time since last dose likely affects vaccine effectiveness for these outcomes more than whether vaccine doses were given before or during pregnancy. And vaccine effectiveness is lower during Omicron predominance compared to Delta in both pregnant and non-pregnant people. And this is likely due to a combination of factors, including mismatch between monovalent vaccine and the variant. Next slide. Now we'll transition to talking about effectiveness of maternal vaccination among infants. Next slide. These data come from the Overcoming COVID-19 platform, which assessed vaccine effectiveness of maternal monovalent mRNA primary series given during pregnancy and prevention of hospitalization for COVID-19 in infants ages 0 through 5 months. Vaccine effectiveness estimates are stratified by variant time period, with Delta in the top half and estimates shown in purple, and Omicron in the bottom half with estimates in black. And estimates are stratified by timing of the second vaccine dose at any time during pregnancy, during the first 20 weeks, or after 20 weeks. Next. What we can see here is that most importantly, maternal COVID-19 primary series vaccination protected infants ages 0 through 5 months from hospitalization for COVID-19, and overall protection was lower during Omicron predominance than during Delta. When vaccine effectiveness was stratified by timing of vaccination, during Delta, effectiveness estimates for hospitalizations were not significantly different. However, during Omicron predominance, vaccine given in the first 20 weeks did not show effectiveness in infants, whereas it did give protection if given after 20 weeks. Next slide. So in summary, COVID-19 can cause severe disease in pregnant people and infants. COVID-19 vaccination of pregnant people is safe for pregnant people and infants. Maternal monovalent mRNA COVID-19 vaccination protects pregnant people and infants ages 0 through 5 months from COVID-19, including from severe disease and hospitalization. And monovalent vaccine effectiveness was lower during Omicron predominance when there was mismatch between the vaccine and the predominant circulating variant. Thus, bivalent vaccines have the potential to improve protection against circulating new Omicron variants. And this is why CDC recommends that everyone, including people who are pregnant, trying to become pregnant, may become pregnant, who are breastfeeding, should stay up to date with COVID-19 vaccines and get the recommended updated bivalent booster when eligible. Next slide. And lastly, as a reminder, CDC's guidance on staying up to date with COVID-19 vaccines and co-administrations of vaccines applies to everyone, including pregnant people. COVID-19 vaccines may be administered without regard to timing of other vaccines, and this includes simultaneous administration of COVID-19 vaccine and other vaccines, such as influenza vaccine and Tdap or pertussis vaccine on the same day. There are additional considerations if administering an orthopox virus vaccine, and these can be found on CDC's website. Next. This presentation reflects the work of many people whom I would like to thank. And next. And now we're ready for questions.
All right, thank you. So I'm going to thank now doctors. Let's see if we can go back. Doctors Ellington, Olson, Carbonda, and Fleming-Dutra for that series of presentations. And these presentations are now open for questions. Dr. Sanchez.
Thank you. Now, it's great data showing the safety of these vaccines. My question is, do we have any data on the monoclonal use during pregnancy? Were these women, the pregnant women, did they, in addition, have monoclonals, or do you capture them?
And thank you, Dr. Sanchez, for that question. In clarification, is that in regards to the vaccine effectiveness data or the safety data? I'll answer from the vaccine effectiveness. I do not believe that that was part of the analysis that was included from the VISION analysis among pregnant people or overcoming COVID, so we don't know that answer. And I'll defer to Drs. Olson and Carbonda regarding the safety data. Dr. Olson, you want to start? Okay, go ahead.
This is Dr. Elise. We don't have that data in VSD for our vaccine safety evaluations.
Will that be captured in the interviews with the VSafe? They're doing the 15 months.
Sorry, Dr. Sanchez, I can't hear you.
I was just wondering if that data could be captured in the VSafe follow-up study that they'll be doing.
Dr. Olson?
This is Christine Olson. That is not information that we're collecting. We're focused on the vaccine, and so we have not been collecting information on the use of other therapies.
Thank you. We'll move on to Dr. Sineas.
Thank you. I have a question about the VSafe data. 45% of participants were healthcare workers. Do we have any subgroup analysis of outcomes in the participants that were non-healthcare workers?
We haven't looked at that yet. We are still working on the further data evaluation of what we're calling phase 1 of the registry. So the interviews that were conducted during during pregnancy and in the 3 to 4 months following pregnancy. And that we have not done subgroup analyses at this time. I'm not sure that we'll have adequate numbers to be able to report out in a manner that'll be helpful, but we are aware and have always been aware that there's a relatively large proportion of our participants that came from the healthcare field just because of their early access to the vaccines based on the staged rollout. Over time, that has steadily declined, and the cohort that we have has become more diverse, but they still are overrepresented within the cohort. Thank you.
Thank you. Dr. Paling?
I want to say thank you very much for the tremendous amount of information that you've shared. And I want to make sure that I've understood it correctly, and I'm trying to combine a whole bunch of different presentations. So, I'm sorry. I can talk into the microphone. What I'm understanding is that under the Omicron epidemic, the rates of COVID-19 in children 0 to 5 months of age is getting close to the 65 years and older, and 3/4 of them are healthy. And that moms that get COVID during pregnancy have an increased risk of being admitted to the ICU themselves. There's an increased risk of stillbirth, there's an increased risk of preterm delivery, and there's an increased risk of neonatal death. And that if moms get the vaccine during pregnancy, it's safe, and there is much better outcomes, and there's protection not only for the mom, but there's also protection for that child. Is that correct? Thank you.
Yes, thank you for that excellent summary.
Yes, thank you. And you missed all of the heads nodding behind you, Dr. Paling. All right, next we'll move on to Dr. Brooks.
Yeah, excuse me, excellent presentation. It's the type of thing we need when we make recommendations to pregnant people. In the first presentation, the overall rate of stillborn was 2.45 for those that were vaccinated. And that slide had a 5.89 on it, said overall. Was that the background rate? I just want to understand what the background rate is for stillborn. Was it 3 to 5%? I just get clarification on that.
What you said initially, the 5.89 is the background rate from the National Vital Statistics data.
Okay.
And the 3 to 5% was for birth defects.
So
background rate.
So it's not showing that the vaccine is actually protective against these things. That's what I'm trying to get to. Is the rate lower among vaccinated in terms of stillborn and birth defect?
I will chime in. There is at least one systematic review and meta-analysis that has been done by Prasad et al. That does show a protective effect among those vaccinated against stillbirth, likely mediated through the prevention of COVID-19 illness. So because there is such a strong effect of illness on stillbirth, of infection on stillbirth, getting vaccinated does protect against that. And so there is some data to show that.
All right, and so that wasn't explicitly stated, so that's actually kind of interesting.
Agree.
Thank you. Dr. Daly?
Yeah, thanks so much. Could you pull up the slide in Dr. Carbanda's presentation? I think it was slide 26, which was a summary of the VSD safety in pregnancy studies. Yeah, that's great. So, Dr. Carbanda, this isn't a specific question for you. It's sort of a backdrop for a point that I want to make. So it would be hard to summarize any better what Dr. Paling just said. That's the most beautiful summary that I've heard. But I think the point that I want to make is that, I think for pregnant women, these are complicated decisions, and they have a lot of things they're considering. One is their risk. Another is their individual risk, but often they're thinking risk to the pregnancy, and then how's their baby going to do? And I think in the context of that, at least what I have heard in talking to women is that they're most concerned about safety. They want to know, is it safe? And they're very risk averse. And so I think, and when these vaccines were first authorized, there was an acknowledgement, we have less data about safety, and that was an explicit acknowledgement. But I think we're in a really different place 2.5 years into the pandemic, and I think that to be able to articulate what's on the slide here and say, the safety is being exhaustively studied and very reassuring, I would hope would provide reinsurance and then increase vaccination rates. And so I guess my ultimate question is, I find this data very compelling, and I can't summarize it better than Dr. Paling, but how do we communicate this as broadly as possible so that we can increase coverage? Over.
Thank you, Dr. Daly. Dr. Long, do you have a way to frame that for us?
No, I wouldn't ever even try. But what I was thinking about is that we have very limited therapeutics for 0 to 5-month-olds who have coronavirus infection. And so I would think that these data are very hopeful in us promoting this is the best way to protect your baby from death from coronavirus. And that's really impressive, and I hadn't seen this before, so it's startled me and is very hopeful. Do we know, Dr. Ellington, of the 0 to 5-month-olds with hospitalization, ICU, and death, what percentage of their mothers were vaccinated? The data that you showed us, I think it was your slide 13. Well, I don't remember what it was.
Hi, Dr. Long. I can answer that question for you. In this particular data, we do not know the percent that were vaccinated in the COVID-19 surveillance.
I didn't hear that. I'm sorry, my hearing problem. What percent of those babies who were hospitalized, mothers, were vaccinated?
We don't have those data in the COVID-19
Okay,
surveillance platform.
Thank you.
Dr. Sanchez?
So, no, and I agree. I think that there's still a lot to be done with only 48% of women having received the primary series. But my question is about the granularity of the infant deaths, and are we capturing any on the multi-system inflammatory conditions in neonates? Is that, I know that might be a separate area, but I do think that needs to be included in terms of the pregnancy and neonatal outcomes. And as an aside, I'm also not surprised about the increase during the Omicron era, because we've seen also higher transmission to normal newborns during the months, during the summer when Omicron was circulating. And our transmission previously had been only from mother to normal newborn, or to in the first few days, had been only like 1%. It went up to like 5 or 6%, and in these babies.
Thank you.
So I'll try to answer for that. Regarding the multi-system inflammatory syndrome in children, the death counts are from the National Vital Statistics system. So if COVID-19 was listed as potentially a cause of death on the death certificate, then that's what's captured in those death counts. CDC separately conducts surveillance for multi-system inflammatory syndrome, and I apologize, our MISC experts were unable to join today for Q&A, but we can follow up with numbers specific to that group. MISC can occur in this age group, but I don't have the numbers at my fingertips.
Thank you. Dr. Long?
Mine was the same question, really asking whether on slide 13, you're using the words "had COVID-19 symptoms" specifically to mean COVID lower respiratory tract-like symptoms, which I think of as COVID, which is adult disease, compared with children who may have at this age sepsis, fever, hypothermia, apnea, or multi-system inflammatory syndrome. I've never seen that in this age group. So do you know, are you using the word specifically, or are you just saying symptomatic with coronavirus infection?
So there's a number of COVID-19 symptoms that are captured in that particular group of COVID-19 symptoms. Dr. Hamid, who did the analysis, is standing behind us, but I also want to refer to Dr. Chris Taylor, who I believe is on the line from COVID-19. He may be able to answer more specifically regarding what's included. It's a very long list of symptoms. Dr. Taylor?
Yes, thank you. Actually, I would refer to Dr. Hamid if she does have that list of symptoms, as you had mentioned. It is a relatively long. I know that we do capture symptoms that are specific to infants, including things like cyanosis, but I don't know if Dr. Hamid might have that extensive list handy.
Yes, so it's a very long list of symptoms. They're non-specific symptoms. Don't have the list right in front of me, but as has been pointed out, it is very broad.
That would, if it's not in publications, it would be really great to include, because we do see a broader range of symptoms in infants. And also wanted to recognize what Dr. Sanchez said about some people are calling it MIS-N, MIS in the neonate versus MIS-C, but it is also a severe consequence of COVID and something that we hadn't seen earlier when we didn't have so many babies infected. So I do see one additional, sorry, Dr. Daly, and then we'll go to Ms. Hayes right after that.
So what I'm trying to do is connect what we know about vaccine efficacy of vaccinating the mom for protection of a 0 to 5 month old, and then this slide, which says 265 deaths with 0.5% of all deaths in this age group. And I don't want to go too far beyond what the data will say, but to me, this seems like it's vaccine preventable death, or at least high potential for these neonatal deaths to be vaccine preventable. Again, I don't want to go too far beyond what the studies show, but if we're preventing disease in infants and infants are dying from COVID, it seems that that's a reasonable interpretation of the data that we see to date.
Thank you. I'm going to go to Ms. Hayes, and then we'll go to, do you want to respond, Dr. Long? Okay, quick response. Yep.
So I agree. So there are several things that have changed. One is we have more data on the safety in pregnancy, and we have more data on the risk in pregnancy for the mother. And the Omicron part is brand new. This is brand new information about vaccine preventable deaths. I think we could use those words. So it seems like it's new energy with new data that ought to inform pregnant women that you can see. Previously, without much data about safety, you might say, I'll take my chances, I'll wear my mask. But now with Omicron really being transmitted in all kinds of ways easier we don't understand, these are vaccine preventable deaths of infants.
Thank you. We'll go to Ms. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. I have a comment and a question. My comment is that I think anytime you're talking about adverse pregnancy outcomes, it's really important that you have the background rate on almost every slide just to keep the data relevant. And I think that Dr. Brooks's question about, is this vaccine actually protective against stillbirth and other outcomes, adverse outcomes? I mean, I thought that was a great question. So my question is for Dr. Ellington on slide 9. And I have some questions about that survey. So my experience is that 77% of women are not vaccinated, pregnant people are not vaccinated. And so I'm curious how this survey was done, how it was sent out, who it was sent to.
So this is the survey data. So the two data sources were provided to sort of corroborate the two rates. And so the first data source is the National Immunization Survey adult module. And within that, they have questions, and it stratifies by whether the woman is pregnant, recently pregnant, trying to become pregnant, or not in those categories. And so I would refer to the citation there for the exact methods on how the National Immunization Survey is implemented, but it is a survey implemented among the adult population and then weighted to be nationally representative. And I will point out, while you haven't asked about the second one, but we provide the second data source as well, which is through electronic health systems. And so these are two different ways to get at what we think the current, overall estimated coverage of vaccination and pregnancy is. And as you can see, while they are not the same, they are similar in terms of their estimates. And so certainly there are things that affect these estimates. With the first data source, response rate is going to affect that. And so those who were unvaccinated may be less likely to respond to surveys. And so there can be some bias in that estimate. But I think the second data source supports that overall receipt of the primary series among pregnant people is quite high. And this is not necessarily that they received the vaccination during pregnancy. Overwhelmingly, these people were all vaccinated before they became pregnant. And then the additional data point is among those who received the primary series, among how many were vaccinated. And then I would also, refer you to the insert there that shows when you multiply the 72% by the 60%, you get 43%. And so that's really how many pregnant people that we estimate are currently either unvaccinated or undervaccinated, which is, more than half of the pregnant people. So there certainly are, limitations to both data sources and the representativeness and, what the response rate might be for the survey. But I don't know if there's anybody else who would like to provide more details on the methods for the National
I would also just be
Immunization Survey
really
data.
curious what the percent of public insurance and private insurance is in this population, because in my experience, I've worked largely with women on Medicaid, pregnant people on Medicaid, and they are highly unvaccinated.
Right.
So
And I believe
I find this data to be a little sketchy.
Yeah, there are several publications with these data, and I believe those publications do provide the breakdown of the insurance coverage for those participants. So we could provide that. You want to go ahead?
Thank you.
And Carol, this is Dana Meany-Delman. Good to hear your voice. We have been trending this over time, and we did see during the Delta period, and especially when CDC released the HAN and ACOG and SMFM and CDC promoted vaccines in the very targeted way during the Delta period, that we did see an increase during that period of time. So I do think it's trended in the right direction, but in general, maternal immunization, we still have a ways to go to promote all vaccines during pregnancy that we know are safe. So I agree with you that inherently we still have a lot of work to do in the space of acceptance of maternal vaccination. And I think Matt Daly's point was well taken: vaccine preventable deaths among kids, but also vaccine preventable deaths among women. We know in August of 2021, we saw a large number of pregnant people in the ICU, and many of them died. So we do have, vaccine preventable deaths for the moms, for sure. We have good data to suggest that. So now we have the added benefit, but we still very much, as a practicing OBGYN, have an uphill battle. And you're right, Carol, it is very hard still to promote acceptance in this population. And hopefully this will help us galvanize more support for that.
And just to add one additional thing too, is that we do see significant differences when we look at various factors, including the insurance coverage, but also by race and ethnicity. And so both these data sources do provide have estimates where you can look at what those estimates are by different race and ethnicity groups, and there are significant disparities there.
Thank you, Dana. Good to hear your voice.
I see one more hand raised in the Zoom meeting. So Dr. Young.
Yes, I wondered if you stratified the infant outcome data for whether they were breastfed or not, and if you did you see a difference?
So this is Dr. Fleming Dutra. I'll speak to the vaccine effectiveness study in overcoming COVID. Unfortunately, information on breastfeeding for the infants was highly missing in that particular study, and so they weren't able to control for it. So we don't know that regarding the overcoming COVID-19 vaccine effectiveness study. And I'm not sure if it's available. It is not available, it appears, Dr. Hamid is saying, in the COVIDnet surveillance data either.
I would suggest that we include it, asking the question, because it may make a difference in your infant outcome.
I'll just add, from the VSD, we do have one study that will include breastfeeding information, the study following up infant infections following maternal vaccination. So VSD is headed in that direction for vaccine safety work.
Wonderful. Thank you.
Thank you. I'm going to call on Dr. Romero.
So Dr. Meany-Delman stole my thunder, but I think it's very important for CDC and I'm glad that this data was presented. It's very important for CDC and put a priority that pregnant women receive their immunizations and boosters. As you have seen, there is data to show that it is safe, effective, and protective for the mother and the infant itself. So again, these data reinforce this, and hopefully people will listen more to the need to get this done. I can tell you that as a Secretary of Health, I heard of cases in my state of women that wound up in the emergency room, that wound up on a ventilator for long periods of time, and some died. And so it is a terrible thing, and we can prevent that. So again, safety of the vaccine and efficacy is well shown.
Thank you, Dr. Romero. I see Ms. McNally has raised her hand, and then I have 2 more hands here.
Thank you, Dr. Lee. Just to follow up on Dr. Romero's point there, for the benefit of the public, can someone please identify the best time frame to get vaccinated during pregnancy? Thank you.
So this is Dr. Fleming-Dutra. So I think the important part is that pregnant people, as well as everyone, should stay up to date with COVID-19 vaccinations, and then the best time to get vaccinated with your bivalent booster is when you're eligible. As we can see from the data that, the vaccine effectiveness during Omicron was lower than it was with previous variants, and this probably likely has a lot to do with mismatch of the monovalent vaccine for the circulating variant. So everyone should get vaccinated and stay up to date when they're eligible.
And I think we need to remember, this is Dr. Meany-Delman, we need a healthy mother to have a healthy baby.
Thank you. Dr. Long.
Just a clarifying question, Dr. Fleming-Dutra. On your slide 49, where you show us the protective effect on the first 5 months of life, are these women who were immunized during pregnancy? I suspect they were, rather than having a history of vaccination.
Yes, Dr. Long, that is correct. So these were pregnant people. These mothers were immunized during pregnancy, and you can see that where the rows are, we have the vaccine effectiveness estimate stratified by timing of the second dose during pregnancy. So that first row under each variant period is any time during pregnancy, second dose in the first 20 weeks of gestation, and then second dose is after 20 weeks of gestation.
So that'll raise the question for the work group to think about, since we don't think that this vaccine protection is long-lived in the population, we've had lots of boosters, will there need to be consideration of boosting during pregnancy or attempting to get to that 6-month or whatever you determine it is, so you can continue to provide the mother protection and the infant's protection?
Yeah, Dr. Long, this is Dr. Oliver. I think continuing to assess both the safety and effectiveness data, both in pregnancy and then in infants, is a top priority of the work group. And so we wanted to get these data out, have everybody aware, because I fully agree that knowing there's vaccine preventable disease in pregnant people and in infants right now. So we need to do what we can with the vaccines and the authorizations we have right now. But yes, we also have a long list of things that we like to talk about for ways that we can kind of optimize the vaccine recommendations in the future, and this is absolutely one of the things that's on the list. Thanks.
Thank you. Dr. Eckert?
Hi, thank you so much for this presentation, for taking the time to really look at this data and present it in this large public forum. I just want to go on the record on behalf of the American College of Obstetrics and Gynecology and just say that we are continuing to work, and we'll work even harder to get this out to all of our providers, that only half of pregnant individuals are vaccinated, and the benefit both to the mom and the baby. And so many of us have cared for these women in the intensive care units and had to make the hard choices of delivery early, et cetera. And so I just want to reaffirm the importance of this data, and thank you for showing the spotlight on it.
Thank you. I'm just going to say one more thing, just to reiterate. I think with full confidence, I feel as a provider, I can strongly recommend this vaccine to my patients, to my pregnant pregnant patients who are about to have children. So I hope this gives that sense of the amount of confidence we've seen, because this is actually very strong data. We'll go on to Dr. Sarah Oliver next for the next section of the COVID-19 session.
Great, thanks so much, and good afternoon. Next slide. So we've previously presented details of the COVID-19 pandemic in children, and then we obviously just heard about the COVID pandemic among infants less than 6 months of age. This slide shows the updated hospitalization rates for pediatric age groups that are vaccine eligible. And you can see that since this past winter's peak Omicron surge and really throughout 22, the 6 months through 4-year age group has had the highest hospitalization rates, again, among the pediatric age groups who are vaccine eligible. Next slide. This slide provides an overall timeline of recommendations for pediatric COVID-19 vaccines and how the vaccine policy has evolved over time. The top row shows the recommendations for the primary series, both expanding the ages down to the 6-month population we saw this summer and broadening to include both mRNA and protein subunit vaccines. Then the bottom row is for booster doses, again, both expanding by vaccines and ages to include the recent bivalent vaccine authorizations. Next slide. Then at previous ACIP meetings, we've discussed booster recommendations for children and adolescents 5 years of age and over for the monovalent Pfizer boosters. For adolescents, the booster recommendations came during the peak of the winter Omicron surge and was informed by safety data from Israel, waning antibody titers and vaccine effectiveness after a primary series in the setting of Omicron, and building on data from the booster recommendations in adults. For children ages 5 through 11 years, recommendations were based both on a clinical trial for booster doses in this age group, as well as the post-authorization safety data from primary series. The booster doses in children ages 5 through 11 achieved antibody levels higher than what was seen after the primary series. The reactogenicity after a booster dose was similar to what was seen after a primary series, and the rates of myocarditis after a primary series in children 5 through 11 were considerably lower than rates seen in adolescents. Next slide. Then for the monovalent Moderna COVID-19 vaccines, the booster dose was studied in around 2,600 children and adolescents with the specific doses and ages listed here. There was one SAE in a child aged 5 through 11 that was unrelated to the vaccine, and no SAEs in adolescents were in the trial. Reactogenicity symptoms were again similar to what was seen for booster doses in other age groups. And antibody levels after the booster dose were 4 to 5 times higher than what was seen after the primary series. So it was based on these data that FDA authorized and CDC recommended Moderna boosters for children 6 through 17 years of age. Next slide. Then, as we heard and discussed at the September 1st ACIP meeting, data were reviewed to inform the bivalent mRNA COVID-19 vaccines for all individuals ages 5 and over who were previously recommended to receive a monovalent booster dose. This included post-authorization VE and safety data from over 600 million mRNA vaccine doses that were administered, clinical data from the bivalent COVID-19 vaccines in over 1,700 people, including antibody studies and antigenic cartography data and modeling data. Next slide. Then ACIP has discussed myocarditis in COVID-19 vaccines numerous times. The risk of myocarditis and pericarditis has been identified after mRNA COVID-19 vaccines. The risk is rare and is primarily observed in adolescent and young adult males within the first week after receiving the second dose of a primary series or the booster dose of the mRNA COVID-19 vaccine. We also know from data previously presented to ACIP that most individuals with myocarditis have fully recovered at follow-up. And the risk of adverse cardiac events were 1.8 to 5.6 times higher after SARS-CoV-2 infections than after the mRNA COVID-19 vaccine among males 12 to 17 years of age. We do also know that an interval of 8 weeks between the vaccine doses may further lower the myocarditis risk. Next slide. Understanding the balance of benefits and risks to inform vaccine policy is critical. It's important to make sure that vaccine policy decisions always take the entirety of the data into account, including the benefits of the vaccine and the risk that the infection poses as well. ACIP has reviewed the balance of benefits and risks regularly. This slide shows the variety of times that ACIP has discussed this for a range of ages and policy questions. And each time, ACIP has evaluated the benefits and risks of these mRNA COVID-19 vaccines. ACIP has determined that the benefits outweigh the risks. Next slide. Then CDC and FDA have conducted rigorous post-authorization monitoring for COVID-19 vaccines. Since authorization, so this is starting in January of 2021, there have been 22 ACIP meetings focused on COVID vaccines. We've had vaccine effectiveness data presented at 11 of those meetings, and safety data has been presented at 20 of the 21 ACIP meetings. CDC evaluates VE through multiple observational studies, employing various methods, and using information collected through different surveillance platforms, electronic health records, or prospective studies. And we know that COVID vaccines continue to undergo the most comprehensive and intense safety monitoring in US history. Then these data are routinely presented to ACIP, currently averaging at least one ACIP meeting a month, where both safety and effectiveness data are presented and discussed. Next slide. For example, this slide was shown back in September for the VE data for emergency department visits in pediatric age groups. The data for these are for the monovalent COVID vaccines, and we eagerly await post-authorization VE data for the bivalent vaccines at upcoming ACIP meetings. Next slide. Then again, as a reminder, this slide was shown at the September 1st ACIP meeting, where we had safety data from the primary series in young children presented, both highlighting no increased risk of myocarditis in this age group and overall the reassuring safety profile. Next slide. Then the next two slides are the myocarditis data from the COVID-19 safety surveillance that was again shown at the September ACIP meeting in those ages 5 and over. These are the VAERS data. Next slide. And then these were the VSD data that were shown in September. Next slide. So now we'll walk through COVID-19 vaccine uptake among children and adolescents. For children 6 months through 4 years of age, 1.4 million children have had at least one COVID vaccine, which is just under 7% of children in this age group. Then among children 5 through 11 years, 11 million first doses, or 38% of children, and 1.4 million booster doses have been given, or 15% of children in this age group who've completed a primary series. Then for adolescents, 18 million have received a first dose, or 71% of adolescents, and 4.5 million have received a booster dose, or 29% of adolescents with the primary series. Next slide. So then this slide puts the vaccine coverage for the pediatric ages in context for other age groups, for at least one dose in dark blue and booster doses in the eligible population in light blue. The pediatric population is highlighted on the box on the left. You can see that the overall vaccine coverage is the lowest among these pediatric age groups. Next slide. So now we'll walk through the overall vaccine recommendations. As a reminder for today, we aren't discussing any new policy for COVID-19 vaccines. These slides are summarizing the existing recommendations that have been discussed at previous meetings. Overall, people ages 6 months and over are recommended to receive a primary series of any age-appropriate, FDA-approved or FDA-authorized monovalent COVID-19 vaccine. Then people ages 5 years and over are recommended to receive one bivalent mRNA booster dose after completion of any FDA-approved or FDA-authorized monovalent primary series or previously received monovalent booster doses. Then with the recent updates, as a note, the monovalent mRNA vaccines are no longer authorized as booster doses. And as we mentioned earlier today, Novavax is now allowed in some populations for a booster dose as well. Next slide. Homologous or the same and heterologous or mix and match booster doses are allowed. There's no preference provided the vaccine age is appropriate. So on that note, people who are age 5, for children who are 5 years of age only the Pfizer bivalent booster is authorized. But then for everyone 6 and over, both Pfizer and Moderna bivalent booster doses are options. Next slide. So now we'll just go over the more detailed schedule for children and adolescents who are not moderate to severely immunocompromised. Next slide. So for children ages 6 months through 4 years, they're recommended to receive either a 2-dose Moderna primary series, separated by 4 to 8 weeks, or a 3-dose Pfizer-BioNTech primary series, where dose 1 and 2 are separated by 3 to 8 weeks, and dose 2 and 3 are separated by at least 8 weeks. Next slide. Children ages 5 through 11 years are recommended to receive either a 2-dose Moderna or Pfizer-BioNTech primary dose. Doses separated by 4 to 8 weeks if Moderna and 3 to 8 weeks if Pfizer. And a bivalent booster dose is recommended at least 2 months after completion of the primary series or the last monovalent booster given. Again, for those who are 5 years only a Pfizer booster can be given, but for those 6 through 11, either Pfizer or Moderna can be given. Next slide. Then adolescents 12 through 17 years are recommended to receive a 2-dose primary series of either Moderna, Pfizer, or Novavax. The primary series is separated by 4 to 8 weeks if Moderna and 3 to 8 weeks if Novavax or Pfizer. Regardless of the primary series, either Pfizer or Moderna bivalent booster is recommended at least 2 months after completion of the primary series or the last monovalent booster. Next slide. So now we'll walk through the vaccine schedule for children and adolescents who are moderate to severely immunocompromised. Next slide. For children ages 6 months through 4 years, they're recommended to receive a 3-dose Moderna primary series, where dose 1 and 2 are separated by 4 weeks, dose 2 and 3 are separated by at least 4 weeks, or a 3-dose Pfizer-BioNTech primary series, where dose 1 and 2 are separated by 3 weeks, and dose 2 and 3 by at least 8 weeks. Next slide. Then children 5 through 11 years are recommended to receive a 3-dose Moderna or Pfizer primary series. Dose 1 and 2 are separated by 3 weeks of receiving Pfizer or 4 weeks for Moderna. And then dose 2 and 3 are separated by at least 4 weeks for both. Then the bivalent boosters recommendations are the same for non-immunocompromised children, where a bivalent booster is recommended at least 2 months. And again, and for age 5, it's only Pfizer. Next slide. Then adolescents 12 through 17 are recommended to receive either a 3-dose Moderna or Pfizer primary series, dose 1 and dose 2, again separated by 3 weeks if Pfizer, 4 weeks for Moderna, and dose 2 and 3 are separated by at least 4 weeks, or the 2-dose Novavax primary series separated by 3 weeks. Then again, a bivalent booster is recommended at least 2 months after completion of the primary series or prior monovalent booster dose. Next slide. Then we do want to highlight that there is some complexity for the pediatric COVID-19 vaccines. This includes vials, labels, and cap colors, but it also includes that the primary series are monovalent and the boosters are bivalent currently, and that the doses and intervals vary by both age group and vaccine. This is just to highlight the need for continued work to streamline the COVID program and to support frontline vaccine providers who are doing the monumental effort to vaccinate children and adolescents. Next slide. So in summary, COVID-19 vaccination is the single best way to protect people from serious COVID-19 illness. COVID-19 vaccines continue to be effective in reducing the risk of severe disease, hospitalization, and death, including against the currently circulating Omicron variants. However, we know that many children haven't yet initiated a COVID-19 vaccine primary series. So we have continued work to do so all eligible children are able to get vaccinated. Then we know that the benefits of COVID-19 vaccination outweigh the known and potential risks, including the very small risk of myocarditis or pericarditis. Next slide. So overall, over 30 million children and adolescents have received at least one COVID-19 vaccine dose. And while that's great progress, there is still much work to do to increase coverage among children. As we'll be discussing today and tomorrow, incorporation of the COVID-19 vaccines in the immunization schedule in the Vaccines for Children, or VFC program, is an important step towards inclusion of COVID-19 vaccines in a routine vaccination program. We'll hear more about the VFC vote next, but I want to highlight that the details of the implementation for the COVID-19 vaccine VFC program will require ongoing work, but the ACIP vote allows the progress to begin. So it's not the finish line, it's the start line. And then we'll hear more from Dr. Santoli about VFC next, but I just want to highlight that the point of the VFC vote is to allow for or underinsured children to have access to COVID-19 vaccines at a time in the future for when the vaccine transitions to a commercial market. We know that both now and in the future, equitable access to COVID-19 vaccines for all ages and populations remains critically important. Again, this includes now, while the vaccines are being supplied by the federal government, and in the future, when we one day move to a commercial program. Next slide. Then typically I'm having to end where we immediately toss to an ACIP discussion, so I'm not always able to appropriately acknowledge everyone, but I just want to very much thank the variety of people. So there is a Corvid and other respiratory virus proposed division that does the lion's share of COVID work at CDC, then an immunization services division, then the immunization safety office that we're always indebted to. Then specifically, I want to call out a small but mighty vaccine policy team. So Evelyn Twentyman is co-lead. Megan Wallace has been our data lead and has done all the ton of the amazing benefit risk analyses and the grade. Monica Godfrey has done a lot of our ETR work. You guys just heard the great work from Catherine Fleming-Dutra, who's done a lot of our pregnancy and infant work. Hannah Rosenblum has been fantastic for immunocompromised populations. Danny and Lauren have been on our data team. Tamara and Ruth are our fantastic VE people. Alicia Hall is the clinical guidelines. She's the one that actually does most of the fantastic, beautiful slides that outline everything. Mary and Sue are on her team as well and do a monumental amount of work. Then Joellen Willicke does all the clinical education material, along with Lauren, Alex, Sarah, and Sierra keeps us all in line. So anyway, I don't often get to kind of acknowledge when we're moving really quickly, but I just wanted to extend my heartfelt personal thanks to this fantastic team that helps us get through what has, again, been on average about one ACIP meeting a month for the last 2 to 3 years. Thanks.
Thank you so much, Dr. Oliver, and also want to extend our thanks to your entire team that seems to keep growing as the number of decisions have multiplied. So we'll open this presentation for questions, and then I just want to acknowledge that we're going to go to Dr. Santoli after this. Dr. Cotton.
Thanks a lot for all the excellent presentations. I had a question about children who are over the age of 12 who are getting basically full dose vaccines. And for the immunocompromised, they're supposed to get usually 3 doses of mRNA in the primary series, but it's recently come to my attention that many pharmacies no longer have monovalent mRNA vaccine, or at least some of them in my region have shipped monovalent vaccine back. So then what would the recommendation be in order to give them a full primary series if monovalent isn't available and if only bivalent vaccine is available?
Thanks, Dr. Cotton. So right now, the primary series is only authorized to be monovalent product, but we're aware that this kind of is emerging as an issue as we've transitioned to a lot of the bivalent supply. We are trying to work with a lot of the vaccine deliveries, both pharmacies and kind of health departments, to make sure that there aren't pockets where there's no monovalent vaccine. So I think we would say if you run into that in an issue, potentially contact the health department, or if it may not be at that local pharmacy, hopefully it's still at one in the area. But we are conveying to jurisdictions to please keep some supply of the monovalent on hand, because there's absolutely people who still need that for right now. But thanks.
Thank you.
Dr. Long.
In a related question, I know there are a lot of strategies being considered for the next generation of vaccines, but is there an anticipated that there will be a bivalent primary series? Because although, there are fewer adults getting immunized initially, all the children are. So it would seem it would be way better if we could get the right dosing and a bivalent. That would be very beneficial. Do we know anything about that or a timeline?
Thanks. I don't have a specific timeline, but I know that studies are ongoing. And so we look forward to a time when we can hopefully bring that data and have those discussions. So it is on the list of things that we're continuing to talk about. And as soon as we have data available, we'll absolutely bring it. Thanks.
Thank you. I'd also like to just emphasize that point. So according to the slides, we just barely have 5% of children under the age of 5 or under who have received their primary series, which means we have an opportunity with 95% to be able to provide them a potential bivalent primary series. So, my hope is that will continue to get prioritized because it is a great opportunity. That opportunity is now, passed for most adults. Any other questions? Dr. Long.
I guess just another statement, as we said before, Omicron has changed the landscape for pediatrics, for pediatric hospitalizations, for pediatric deaths. And unfortunately, for some reason, this safety issue in the very young ones came up and got a lot of legs from misinformation. That has, I think, made people think they'll just wait and see for their children. They'll take the risk for themselves, but they won't take the risk for the small children. We have to get the message out that it is not, just the saving of a couple of days of a cold, but that this is a serious illness in children, and that there's a vaccine that's available and they should have it.
Thank you, Dr. Long. Dr. Daly?
Yeah, I do want to discuss this point a little further. So I've been tremendously worried about the complexity of the program, including at the primary care and immunization clinic delivery site. And even though I'm actively in the work group, it's hard for me to know kind of what the time frame is for that. And I think we need to work closely with the FDA and with the vaccine manufacturers to really sort of say, in order for us to improve and simplify the schedule, what needs primary data in a clinical trial versus what can be inferred? I will, bring up a number of examples. So this is not just simply we just need more education of frontline providers. That actually is in my mind, the wrong answer, even though that's part of the solution. It's really about is there a way not to have a special row in every table for 5-year-olds? Okay, and does there need to be a clinical trial to do that or not? That's more minor in a way than this issue about are we moving towards bivalent primary series, and then where are those studies and when are they going to be done? I think we need to be explicit about what needs clinical trial data, and then who's doing those studies, and when are they going to get to the FDA for review, and then when do they get to this committee for deliberation? So I think we just need to keep pushing that point as much as we can. Thank you.
Thank you, Dr. Daly. I don't see any additional hands raised at the moment, so I'm going to take the opportunity to turn it over to Dr. Jeannie Santoli to provide a presentation on VFC.
Hi there. I actually have two little stats I wanted to share with you all as we get started with this. On November 2nd, 2021, CDC endorsed the recommendation for the vaccination of children aged 5 to 11. This was the first pediatric vaccination for younger children for COVID, and we are now 351 days since that event, so we're actually just less than a year. And then on June 21st, 2022, there was a rollout of COVID-19 vaccine for children less than 5 to 6 years of age, and that's been 120 days today. So the world is moving at lightning speed because of your work. So I just want to say that before the resolution and get started. This is all going to look very familiar to you all. Next slide, please. So the purpose of this resolution is to add vaccines for the prevention of COVID-19 to the VFC program. Next slide. The eligible groups are all children aged 6 months through 18 years. Next slide. The recommended schedule, dosage, and intervals, COVID-19 vaccines are either authorized under emergency use authorization or approved under a biologics license application, are to be administered according to the most recent age and vaccine appropriate schedule included in CDC's interim clinical considerations for COVID-19 vaccines, with a link. Next slide. The recommended dosage, there's a referral to the FDA page where the fact sheets are listed, and the contraindications and precautions are available in CDC's interim clinical considerations for COVID-19 vaccines with the same link. Next slide. So I wanted to add this, and this really just underscores what Sarah explained earlier, because it seems very important to make sure that everyone is aware of what this VFC resolution is for and how it's timed a little bit differently than VFC resolutions usually are. So COVID-19 vaccines will not be available through the VFC program immediately following the passage of this resolution, because they remain available for all Americans under the national COVID-19 response. But following the passage of this resolution, we will begin some additional necessary steps to awarding contracts for COVID-19 vaccines. And then once the vaccines are commercialized and therefore no longer available under our national COVID-19 response, then VFC providers will be able to order vaccines through the VFC program. And the timeline for commercialization of COVID-19 vaccines in the US has not been finalized. And that concludes my presentation.
Thank you, Dr. Santilli. Are there any questions for Dr. Santilli? We will have to move to some vote language, but I just want to make sure we can add any clarifications or questions. Dr. Romero?
I just wanted to make sure that everyone understood that this is not a policy change, nor is it a mandate for the use of the vaccine. It is a way to ensure access to this vaccine for those individuals, those children that don't have insurance. So I really wanted to make that clear. Thank you.
Thank you, Dr. Romero. Dr. Cotton.
I'm not a pediatrician. Are there vaccines that are currently recommended for children that are not covered by the VFC? People are shaking their head no. So, so just to clarify, any vaccine that is recommended by the ACIP is covered?
A clarification on that? Oh, I'm sorry. Go ahead, Melinda. I didn't see you.
Yeah, travel vaccines are not routinely included in the Vaccines for Children program. So there was a vote to include, ACIP recently voted for the cholera vaccine for children who were traveling to areas with active cholera transmission. And we did not have a VFC vote for that.
And can I just ask Dr. Romero to just clarify that again, that it would not be a mandate, this would not be something that because it's covered by the VFC that schools would mandate, it would not be. Can you just elaborate a little bit on that to help us out?
Right. So again, let me state the second part of what I said, which is this is an access issue. This is an issue to allow children that don't have insurance to gain access to this vaccine. It's particularly important as we move on to commercialization of the vaccine. It is not listing this as a routine vaccine for children to enter school. And it is not a change in our policy for these vaccines, for these routine vaccines in children.
CDC does not.
Right. And as Dr. Cohen is telling me, and again, reminding me, which you should all know, is that CDC doesn't make state recommendations for vaccination, right? That is a state issue about what vaccines are required for school attendance, right? So that's another issue totally separate from this.
Thank you very much for the clarification.
I see Ms. McNally. You have your hand raised.
Yes, thank you. I am thinking about the countermeasures injury compensation program versus the vaccine injury compensation program. Does the availability through VFC render this a covered vaccine now, or is it still a covered countermeasure? Thank you.
So the VFC vote does not impact inclusion in the countermeasures injury compensation program. There's specific steps that have to be followed for a vaccine to be added to the vaccine injury compensation program, and inclusion in VFC is not part of that process.
Thank you, Dr. Wharton.
Thank you, Dr. Wharton. Dr. Hoag?
Thank you, Dr. Lee. One quick question and then one comment. I'll ask the question first. Do we have a rough idea of when most of the monovalent pediatric approved vaccine that's currently available in the marketplace will expire? Uptake has slowed. We obviously saw that we need to see that uptake increase and improve for primary immunization, but do we have any idea when that's going to expire? And would that give us any insights into when the commercial program might need to be starting, because the manufacturers are going to have some incentive to produce primary series vaccine? So that's my first question, then I'll have a comment.
Hi, this is Sarah Meyer from the Immunization Services Division. So we do know that a large proportion of our monovalent mRNA vaccine stock would be expected to expire over the next couple of months. However, there are some unknowns here, like we mentioned, the unknowns about the availability of bivalent mRNA vaccines for primary series, whether these expiration dates could be extended, and just several things that are currently unknown, but that we expect to be able to work through in the next couple of months. So right now, as was mentioned earlier, we do still have sufficient supply of the monovalent mRNA vaccines. As Dr. Cotton brought up, we are aware that in some locations, people are having less and less of that, but the vast majority of people in this country still live within 5 miles of a site that carries the mRNA vaccine. So over the next couple months, we will continue to work through these issues, but appreciate you bringing them up. Thanks.
And then my comment is that as the COVID vaccines for children and adolescents move to the commercial market, one concern that I have is that, especially as COVID vaccines became available early on for adolescents 12 years of age and older, many of those doses were given in pharmacies. And historically, in most states, pharmacies are not approved as VFC providers. I think there's less than 150 or something like that VFC providers that are pharmacies around the country. And I think from a policy standpoint, CDC and the state departments of health really need to take a careful look at that going forward. I am concerned about adolescent patients in particular perhaps not getting immunized. And I think pharmacies do offer a good option for getting vaccinated, and the pharmacists can advocate with the patient and with the parent for their need for a primary care wellness visit from a primary care provider at the time they give that immunization. So I just ask that that be considered or thought about and perhaps actively discussed going forward.
Thank you, Dr. Hoag. We'll move on to Dr. Duchin.
Thank you, Dr. Lee. Can I make a comment about the VFC program?
Please go ahead.
Thank you. I would like to remind folks that in June 2021, the National Vaccine Advisory Committee produced a report with recommendations for advancing immunization equity. And that report recognizes that immunization equity is a long-standing and persistent barrier. Inequity is a long-standing and persistent barrier to immunization uptake for almost all of our recommended vaccines. And underlying systemic barriers and biases in the immunization system exist, and they need to be removed to create a truly optimal health for all system. A recent publication in Health Affairs reminds us that since its enactment, the Vaccine for Children's program has lifted immunization rates across all children, significantly reducing financial and racial inequities in childhood immunization rates. And its successes have been measured not only in healthcare access, but in health outcomes. It prevents or has prevented millions of cases of serious diseases, including hospitalizations and deaths, and net savings to insurers have been estimated in the billions of dollars, and societal savings from the reduced impact of preventable disease in the trillions of dollars. Yet our Black and Hispanic and Asian community members who are adults have lower vaccination rates than whites for all recommended adult vaccines. For example, adults with health insurance have vaccination rates 2 to 5 times higher than people without health insurance for influenza, shingles, HPV, and other diseases. So with respect to today's discussion about the VFC program for COVID-19 vaccines, I wanted to highlight the NVAC recommendation that we really need a vaccines for all program, children and adults. A vaccines for all program should be created and operated in parallel with the VFC program that could provide vaccines at no cost to the recipient, regardless of their age, so that financial barriers to both COVID-19 vaccines and all other ACIP recommended routine vaccines are removed. Thank you for the opportunity to comment.
Thank you very much, Dr. Duchin. Dr. Lear.
I would like to strongly second that recommendation. It is a wonderful idea.
Thank you, Dr. Lear. Thank you so much. And I think we will now move on to putting up the vote language for the VFC resolution. Okay, this one I might be able to read, Dr. Santilli, but I will turn it over to you.
So the vote is approve the vaccines for children resolution for COVID-19 vaccines.
Thank you. Simple and straightforward. Any questions? Dr. Long.
I'm just bringing to your attention, the agenda says this follows the public comment. Is it?
We have to put the motion on the table, and then we go to public comment, and then we will vote.
I'm sorry.
Yeah. Dr. Paley?
I wanted to make a motion to accept this.
And I'll
Thank you,
second
Dr.
it.
Paley. It's been moved. Would anyone like to second? Ms. Bata?
Second.
I second that.
Thank you, Ms. Bata. So it's been moved and seconded that we accept the vote language that is put on the slide in front of us. So we will now move that to the vote section. But at this moment, I believe we are actually running on time. This is a miracle. And COVID-19 actually got us back on time. So we will take a 15-minute break and plan to reconvene at 3:30 for public comment. I want to thank all of our speakers. That was a really helpful and informative session. Thank you, everyone.
Hello.
Thank you, everyone. It is now 30 minutes after the hour, and we'll now reconvene the meeting to begin our oral public comment. I'd like to welcome and thank our public comment speakers today for addressing the committee. All the speakers submitted a request in advance of today's meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. And as a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at today's meeting. Thank you again to our speakers, and we look forward to your comments. Our first public commenter for today is Dr. David Wiseman. Dr. Wiseman, you can unmute. There you go.
Can you hear me okay?
We can hear you. Thank you. Please go ahead.
Thank you very much. CDC and FDA's extension of the bivalent booster EUAs to the young children without VRBPAC or ACIP votes exudes regulatory steamrolling that avoids questions about extrapolations from data described by FDA as preliminary, imprecise, and potentially unstable. the use of not scientifically established immunobridging data per FDA, the relevance of extinct Wuhan and BA1 strains, and BA45 data based on as few as 8 mice. CDC asserts that FDA says that these vaccines are safe and effective. No, the EUA standard is may be effective, which FDA have lowered further. FDA have introduced a 2-month boost interval, likely due to evidence of negative efficacy by 3 months. Does this signify immunological harm? ACIP's efforts to revise this interval were rebuffed, despite other examples of CDC modifying FDA decisions. mRNA vaccines are not flu vaccines, which are not gene therapies that turn your body into a factory for a toxic spike protein. Questions asked by Verbac's Dr. Portnoy and ACIP's Dr. Sanchez about the locus and duration of spike production and crossing the placenta have been repeatedly evaded. FDA's guidance on variant vaccines applies to monovalents made by a prototype process. Bivalent production raises significant QA safety and efficacy implications. At the last ACIP, Moderna revealed that the 2 mRNAs in their bivalent product generate heterotrimers. Is their vaccine tetravalent with 2 homotrimers and 2 novel heterotrimers with unstudied pharmacology and toxicology? Today's pregnancy discussion spotlights CDC's recommendations that circumvent manufacturers' off-label claims outside of FDA-approved instructions, stating that the data are insufficient to inform vaccine risks in pregnancy. If the data are robust, let FDA modify the label. More concerning are two VSD studies, 1346 and 1345, including some of today's presenters, which stated pertinently, now that the pregnancy is not a contraindication, there is an urgent need to monitor the safety of these vaccines during pregnancy. You cannot recommend a product saying it is safe without informing patients of the urgent need to study its safety and seek to waive the requirements for informed consent. Alarmingly, since the conditions appear to have been created where not only pregnant women participated in the study without their knowledge, they may have been coerced to do so by federal and other mandates. Along with CDC's ignoring safety signal studies by NIH, scientific standards have been eroded beyond recognition and ethical standards may have gone the same way. A more robust discussion of the safety and efficacy of these products must occur, including before they are added to the VSC program. ACIP members, please demand answers, and thank you for your work.
Thank you for your comment. Next, we'll move to Ms. Catherine Falk.
Hi, good afternoon. I am Catherine Falk, a parent and vaccine advocate in Oakland, California. I see you have a lot of business to get through this week, and thank you for all that you do. I want to focus on the portion of your agenda concerning the Vaccines for Children program. VFC is a valuable tool for ensuring that children have access to vaccines regardless of their family's insurance status or ability to pay. In the disruption of the pandemic and the economic turmoil of rapid inflation, this program is more important than ever. Routine vaccination rates slipped somewhat during the pandemic in the United States, and it's crucial to get back on track, especially now that most pandemic precautions such as masking have been dropped, and emergency funding for COVID-related expenses is nearing its end. For these reasons, I strongly support the addition of the COVID-19 vaccine to the list of routine childhood vaccines that VFC will pay for. Learning to live with COVID means ensuring all children are protected from it, and making sure money isn't an obstacle is so important for families. There's no good reason not to add the vaccine, no good reason not to help families afford preventative care for their children, no good reason to let a single child miss a vaccine because their parents couldn't afford it. As I was sitting down to write this comment, I saw that Tucker Carlson decided to take aim at the VFC and at ACIP and the CDC in one of his tweets. If I could address him directly in 10 words or less, I think I would say, shame on you for endangering children and public health. I am sorry he has made your job that much harder with his fear-mongering. The work of combating misinformation continues. To those misled by Tucker's tweet, no matter what he says, only states can mandate vaccines for school attendance. Thank you.
Thank you for your comment. Next, we have Mr. Burton Eller. We'll move on to the next public comment speaker and come back. The next public comment speaker is Bob Runnels.
Hello, Bob Runnels. I'm a Washington State parent, extremely concerned about the health of future generations. This committee has been very successful at injecting children, usually against childhood diseases. The CDC has continued to add to the vaccine schedule since 1986, when liability protection was granted to vaccine makers. Today, families who follow the schedule will have their children injected 54 times with 73 doses of antigens for 16 diseases before they graduate. Since 1986, there have been no commensurate improvement in the overall health of our population. The US ranks poorly in many categories with very disturbing trends like the unexplained autism epidemic. Now, the elephant in the room. COVID is not a childhood disease. COVID vaccines, which I will refer to as COVID shots, are not medically indicated for the young. Their amazing immune systems can be strong if not hampered with. What's more, it is now widely acknowledged that COVID shots don't stop transmission. So it cannot be said that these shots save others from getting infected. The marginal benefits from these shots wane quickly, faster than for any other injection on the schedule. COVID shots are not well targeted to circulating variants. I don't care how fast trials are conducted, even mRNA technology cannot be fast enough to address a new microbe, except for maybe when using gain-of-function or dual-use research. So many of the public see what's going on. We notice when the vaccine definition was changed. We notice when the phrase vaccine failure was changed to breakthrough infection and immune escape. It's all vaccine failure. We've seen the death certificate criteria change to favor COVID death rates, confounding from and with. We see the huge government-funded efforts to market these products in TV, radio, print, billboards, online. Shouldn't they sell themselves if they're so good? The majority of parents know their kids are not at measurable risk, yet the public health apparatus tries to convince us otherwise. Parents see and sense that something is wrong. Our radar is pinging. We see other countries like Sweden and Denmark with very clear policy shifts against injecting children. Does the CDC consider how other countries are making their decisions? Yet there's this rush to recommend kind of approved COVID shots for ever lower ages. We see the ACIP as one of the many government bodies and private interests bending rules to mandate COVID shots. We know the CDC childhood schedule is the golden goose, granting liability immunity to pharmaceutical companies who, by the way, do all their own testing. You must vote no on any new shots to any of these schedules for COVID or other diseases. Our young little pin cushions are already exposed to too many attempts at artificial immunity. To reduce risk, the ACIP should be finding safe ways to reduce the childhood schedule as VPDs diminish. 4 polio shots? Really? Vote no in adding vaccines to shots in any schedule. Be extra critical of the studies and talking points aimed toward you. The data must be overwhelming if the committee adds anything to the already bloated schedules. Vote no.
Thank you for your comment. Your time has expired. We'll move on to the next public comment speaker, Thayer Phillips.
Hello, my name is Thayer Phillips. I am the national spokesperson for Seniors Speak Out and have been an advocate for older Americans for over 25 years. I appreciate the opportunity to speak today and thank the committee for the extraordinary work and dedication they have provided over these last very difficult 2+ years. Before I go on, I want to say that I recognize that there have been important discussions this morning that I want to acknowledge and assess. I ask the committee to keep in mind that the clearer, the simpler, and the more direct the language, the better patients will understand and the better the chances will be for higher rates of vaccination. We find ourselves today in a situation so much better than we could have imagined in those early awful months of the pandemic, when fear and lack of both effective treatments and preventive measures took an unimaginable toll on people from all walks of life, especially older Americans. ACIP's prompt action in prioritizing older Americans' access to COVID vaccines saved lives and prevented hospitalizations. How far we have come. But the fact remains that there are still serious public health challenges facing men and women of advancing age. As 2022 nears its end, we worry not only about whether there will be a spike in COVID, but also about the impact of flu and pneumonia, whose persistence carries on decade after decade, with pneumonia remaining one of the top 10 causes of death for older adults. Reports forecast that flu season is very likely to be bad this year. So it stands to reason that now is the time we must prepare ourselves to do everything we can to prevent these old foes from overwhelming those of us who are the most vulnerable. Before COVID, pneumonia caused approximately 1.5 million annual emergency room visits and nearly 50,000 deaths. Though today we see these statistics through a post-COVID lens, we must not forget they are truly horrific. And it is equally important that we remember that there are ways to change them for the better. We urgently need access to the updated pneumococcal vaccines that FDA approved last year. Older adults who are previously vaccinated with earlier pneumococcal vaccines need to know when and if they can be given the newer versions. This year, this season, we need them more than ever. Please act today so that this effective protection is available before another winter season takes its toll. And please, once again, the clearer and the simpler the recommendation, the better for the provider and the patient and the outcome. Thank you.
Thank you for your comment. We'll move on to our next public comment speaker, Mr. Mark Gibbons.
Good afternoon. My name is Mark Gibbons. I'm the president and CEO of Retire Safe, an advocacy organization which represents the concerns of middle-aged and older adults. As we navigate a third year of the COVID pandemic, healthcare concerns have quickly risen to the top of our priorities. A bright spot in this difficult time is how older Americans have really embraced the protections offered by the innovative COVID-19 vaccines, with 95% of Americans aged 65 and over having received at least one dose of the vaccine. While we continue to communicate around the very real threat which COVID-19 poses to the respiratory health of older Americans, we have also remained steadfast in ensuring our community understands the risk of other diseases such as influenza, pneumonia, and RSV. Even before the pandemic, we knew that older Americans are more likely to become seriously ill and die from respiratory disease such as the flu and pneumonia. Today, as we continue to also face the unpredictable COVID virus, older Americans are feeling incredibly vulnerable and are seeking to take advantage of any way they can to protect themselves. This is why we are hopeful that the committee will vote in favor of recommending the use of the new pneumonia vaccines in those Americans aged 65 and older who have already received a previous dose. Our community listens intently to their physicians when it comes to how to best protect their health. By offering a clear and simple recommendation for providers on the use of the new pneumococcal vaccines for older patients will go a long way toward reducing the burden of the disease on some of the most vulnerable members of society. Just as older Americans aged 65 and over have embraced protections offered by the COVID-19 vaccine above any other age range, we believe that a vote today to expand access to the new pneumonia vaccines would also be welcomed by this community as another important tool that they can use to support a long, healthy life. We are grateful for the committee's ongoing efforts to protect Americans and especially American seniors. For our part, we will continue to educate and inform our communities on the important steps they can take to protect themselves. Thank you.
Thank you for your comment. And we'll go back to Mr. Burton Eller.
Thank you. We had trouble getting the link out to the country in rural America. My name is Burton Eller, and I'm speaking today on behalf of the National Grange, the nation's oldest organization representing agricultural, rural, and small-town American life. Today's discussion on the qualified guidance for the use of the pneumonia vaccine hits particularly close to home for us. Our own National Grange president, Betsy Huber, is currently recovering from pneumonia. She's doing very well now, but was very sick and was very grateful to have had the vaccine so that it wasn't any worse. Suffice to say, we are very concerned to hear this morning's discussion on the additional assessment for the use of the new broad pneumonia vaccines for individuals 65 years and older who may have already received a dose of the vaccine. In rural states and counties across the country, Americans are living in a risk of serious respiratory illness. Rural Americans are 42% more likely to die from COVID than their urban resident counterparts. And just before COVID, the rates of influenza and pneumonia were higher in rural counties than in urban. Two factors contributing to this are the fact that more Americans living in rural communities are older and access to care is limited. Since 2015, 183 rural hospitals have shut their doors. Nearly half of those still in business face negative operating margins, and 1 of every 4 are now at risk of closing. And on average, rural Americans live twice as far from a hospital than those living in urban areas. Because of this, we believe vaccines are a critical option for protection of those living in rural communities who are more vulnerable to serious respiratory illness or death. The National Grange recently signed a letter to Dr. Melinda Wharton, along with 21 other aging, consumer, and patient stakeholder organizations, expressing our support for clarified, straightforward guidance on the use of the newest pneumonia vaccines. We are grateful to the Pneumonia Working Group for evaluating the need for this clarified guidance. Rural Americans already face so many barriers to care, so we ask that this committee keep in mind that those patients need their physicians to have clear recommendations from the CDC in order to provide a comprehensive care, as comprehensive care as possible during the limited time they may have with their patients. We are grateful to the committee and hope it will vote in favor of the most straightforward recommendation for these new vaccines so that these Americans who would most benefit from this added protection are able to do so. We thank the ACFP for your work on these important vaccines and will do our part to make certain rural Americans know what could soon be available to them. Thank you.
Thank you for your comment. I want to thank all of our public comment speakers for today, and I also want to thank those who take the time to submit written public comments via the CDC docket as well. And with that, we will now move on to the voting session. We have first, we will look at the pneumococcal vaccine votes, and there are three. We're going to go ahead and do VFC first, per Dr. Wharton. I'm delighted to switch up the order. Okay. So if we could please put the VFC vote language up. Thank you so much for your flexibility. Thank you. So this is the vote language that was moved and seconded to approve the Vaccines for Children resolution for COVID-19 vaccines. I'm going to ask at this time if there are any additional questions or issues the committee would like to discuss before this vote. I don't see any hands raised. Let me just confirm. All right, I don't see any hands raised. So I'll assume that the committee has no objections to proceeding with a vote. I'm going to ask the ACIP members to please turn on your video. And I will ask you to state your name and whether you have a conflict of interest, and then your vote. Just hold on one moment. I have to turn on my video. Thank you. We'll go ahead. So just one moment. We're going to wait till everybody can get their video on. Thank you. We'll start the voting with Dr. Talbot.
Talbot, no. Kip Talbot, no conflicts, yes. Oh, I'll just turn on your.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
The mic and
Oh, you need to use your speaker.
yep, you got yep, yeah, your speaker has to be turned off.
Yeah, it was. It was turned on.
Apologies. We're going to get this hybrid meeting to work in a moment.
Oh, now do I have it? Why don't we, did you want me to talk through my computer or through the microphone?
Take it off.
I did, and I did.
Apologies, it turns out hybrid is much more complicated than web only. All right, so did I get to Dr. Chen? Dr. Chen?
Are we back on?
Okay. Thank you. I'm going to check to make sure folks can hear me. I'm going to actually move to Ms. McNally.
McNally, no conflict, yes.
Thank you. Dr. Bell?
Bell, no conflict, yes.
Thank you. Dr. Lair?
Lair, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Daly?
Matt Daly, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Shaw?
Shaw, no conflicts, yes.
Dr. Long?
Sarah Long, no conflict, yes.
Dr. Cotton?
Cotton, no conflicts, yes.
Dr. Sineas?
Sineas, no conflicts, yes.
Dr. Paling?
Paling, no conflicts, yes.
And Lee, no conflicts, yes. This vote now passes with 15 yeses. Go ahead, and 0 noes.
Yes, the vote passed, 15 zeros, or 15 for, no against.
Excellent. Thank you. We will move on to the next set of votes, which is the pneumococcal vaccines. If we could please bring up the vote language for the first vote. Let me just confirm. Dr. Kobayashi, thank you. I just want to confirm. So is this the original vote language that we made a motion on? Okay, let's review the original language, and then I know that there was discussion that our colleagues wanted to have around the wording.
Okay, so the first proposal was adults who have received PCV13 only are recommended to receive a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended, to complete their pneumococcal vaccine series. This was the original presented this morning.
Thank you. And after the discussion that we had earlier, could you please put up if there is revised language?
Yes. Could you go to the... Okay, so the revised language after the discussion this morning is adults who have received PCV13 only are recommended to complete their pneumococcal vaccine series by receiving either a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended. And then the sub-bullets clarify which population we are talking about. Adults aged 19 to 64 years with an immunocompromising condition, cochlear implant or cerebral spinal fluid leak, and adults 65 years and older who have received one PCV13 only. And so the changes are, we put forth the recommend to complete their pneumococcal vaccine series to the front, earlier in the language. And then we also put either or to make clear that there are two options to complete the recommended series.
So I just want to clarify that the vote language is what's in italics, the part up top, but we did ask, per Dr. Lehrer's comment earlier, to just clarify in the accompanying text which groups this would apply to. So we anticipate the vote language would be the italics up top. I'm getting a yes. If amended. Dr. Talbot.
So just to clarify, so if you're a diabetic or a smoker, are you not eligible to get PCV 20?
Dr. Kobayashi?
Yes, thank you. So if you were diabetic under age 65, these people were not recommended to receive PCV13 previously, so we're going by the groups who were previously recommended to receive PCV13.
But it was my understanding when we voted for PCV 15 and PCV 20 that we combined all the high-risk groups under 65 years of age, and that included those with diabetes and smokers. So I'm a little worried that now we're pulling them out and making it more confusing.
Dr. Kobayashi?
Sure, I can answer that. Yeah, thank you for that question, Dr. Talbot. So yeah, so those people were previously recommended to get PPSV23. So we do recommend PCV20 or PCV15 for those adults. And then if they're vaccine naive, then those people are recommended to get PCV20 or PCV15, including those who are diabetic, chronic heart, lung disease. So we're only talking about those who received PCV13 based on the previous recommendation.
Dr. Paling, did you want to add anything? Dr. Long?
What this says then, if you give the option of PPSV 23, that those who took that option would then need to get an additional dose of 20 at age 65.
Dr. Paling, would you like to respond?
Is that what was intended?
Or Dr.
By keeping the PSV 23 in there is a little bit confusing.
So yes, so by PPSV23 as previously recommended, so these people will continue to get PPSV23 based on what's currently recommended. So that would include, repeat dosing and one and final PPSV23 at age 65, if they go that route.
Dr. Brooks? Well, so actually, it's so great that we're having this conversation because I think we are further clarifying and making sure that we are not confused as we make this recommendation. Dr. Brooks, please go ahead.
And just simple clarification, we're not adding a new vaccine to the guidance, we're just replacing one with another.
Yes, that is correct. So currently, these people are recommended to receive PPSV23, but then we're saying that alternatively, they can get one dose of PCV20 and then complete their recommended series as an alternative.
And just as a quick follow-up, so therefore all the cost effectiveness data, was it this? This is what we were looking at?
Yes, that is correct.
Dr. Talbot?
I now understand that that group previously had not been recommended to receive PCV 13, and I appreciate the reminder. I guess just for clarification, it might just be easier. I don't know that, I think everyone who's received PCV 13 in the past who's one of the high-risk groups, and if they accidentally got it or didn't get it or whatever the situation is, I just think it'd be more clear that everyone who previously received PCV 13 would be eligible for PCV 20. And without that, just the clarification confuses me. That's all.
So that's exactly the wording of this phrase. And then we're telling you the people who are most likely to fall into that category. And then as a reminder, we're trying to keep this broad because if some practices are not carrying PCV20 and want to make sure people get coverage in whatever way is available.
Dr. Daly, and I am going to encourage the conversation because I think the more that we can sort this out here, the clearer we'll make it for everybody. So Dr. Daly and then Dr. Shaw.
Yeah, I mean, I'm concerned about defining people by what vaccine they received as opposed to their age and their presence or absence of a chronic condition. Even though I understand the intent, because it's referring to a specific group, but to me, that's runs the risk of adding to confusion. Over.
I'm going to go to Dr. Shaw and then Dr. Bell.
Thank you. One is two questions. One for Dr. Kobayashi. This goes back to the discussion earlier this morning about administrative simplification. Is it the case that a provider or a state health department in their Vaccine for Adults program, their view from an inventory management perspective could be simplified here because they need not carry both PPSV23 and PCV20. They could stop carrying PPSV23 and still provide recommended care for their patients. That's correct?
So that was something that was brought up by during the work group discussion in terms of inventory management. Exactly as you said, some providers don't carry the polysaccharide vaccine. In that case, they can complete the recommended series for these adults who started the series with PCV13 with a dose of PCV20. That's the intent of this recommendation as an option.
My other question, it goes back to the cost effectiveness analysis, and my colleague Dr. Brooks alluded to this a moment ago. I don't know how much that weighs on the decision or steers the decision here, because your slides from this morning also made a strong epidemiological case for the benefit of PCV20 versus PCV13. All that said, I had the impression that the cost effectiveness analysis presented a scenario in which the patient contemplated here, an adult who received PCV13, would get nothing rather than PPSV23. I'm not sure if that's A, correct, or B, the extent to which that alters the ultimate decision here because of the strength of the epidemiological data, but it is a question that's still on my mind.
Thank you for the question. So if the question was, what the model was actually doing, so there were actually, as you saw, multiple models that reviewed. So there were models that looked at PCV13 plus PCV20 versus no additional vaccine, but there were models that looked at PCV13 plus PCV20 versus PCV13 and PPSV23. So we considered all of that. We didn't present everything today.
Thank you.
Dr. Talbot?
Yeah, I appreciated Dr. Daly's comment and was hoping that he could give an example of language that he thinks would be better. Not to put you on the spot, but I really liked your thought.
I'm going to give Dr. Daly a moment to think, and I'm going to call on Dr. Cotton, and then I'll come to Dr. Daly.
I just want to confirm, this doesn't seem to be accurate to me because so I take care of immunocompromised patients, and if they had PCV13, then they are supposed to get PPSV23 8 weeks later.
Yes, so for PPSV23, it's 8 weeks later, and that's why we had to put or PPSV23 as previously recommended after PCV20 at least 1 year later. So that, the PPSV23 as previously recommended includes multiple groups. So there are the immunocompromised who gets it 8 weeks later. There are adults without immunocompromising conditions, but 65 years and older who get it 1 year later. So there are all these different groups, but we're trying to address this by saying, if you started a series with PCV13, but haven't gotten any PPSV23, you can get PCV20 as an option and just be done.
So I think that this isn't going to work in a clinical scenario because people won't understand that and they don't know. I can, from my experience at my large academic hospital, people don't know where to find the information and then won't understand how to get this. And then we are very busy in clinic and won't have the time to look this up. So it can't be that many steps. And to me, I thought that this meant PPSV a year later, based on the wording. I do understand what you mean, but this isn't going to be clinically as useful as we would like. But Matt, Dr. Daly's going to tell us the wording that will save us.
I'm going to give him a break for another minute, and I'm going to call on Dr. Bell, and then I'll come back to Dr. Daly and Dr. Long.
Well, thank you. I'm not sure if it was worthwhile to call on me because my question may be completely silly, but I'm just wanting to make sure that we don't further confuse ourselves. I'm thinking about the third potential recommendation that we're voting on, which has a choice of clinical decision-making versus a recommendation. And are we adding to the group to which that is going to be applied by what we're saying here about people older than 65? I mean, it just seems like that's going to be like an additional confusion. If you are older than 65, you've only had PCV 13, you decide to get PPSV 23, and then you're also going to be told that you maybe should get PCV 20. Am I incorrect about this?
Dr. Kobayashi. Thank you, Dr. Bell. So in the case of adults 65 years and older, if they got PCV 13 and a dose of PPSV 23 at or after age 65, then they're considered complete with the recommended vaccination series. So they will not be, well, it depends on what we decide on for the recommendation for adults 65 years and older. That's the third option. But based on the current recommendations, those, if you're 65 years and older, if you get PCV 13 and a dose of PPSV 23 at age 65 or later, then they're done.
Right, but I'm sorry, but that's my question. I'm just worried about considering this, assuming nothing else changes, if in fact one of the things we might change is related to this and is the third vote. Anyhow, that's what I'm concerned about.
Thank you. I think that's really good feedback. And before Dr. Daly even comes up with another recommendation, I'm just going to state that I think what we're going to do, and thanks to Dr. Romero for allowing this, but I would like to continue this conversation for the time we have remaining today. But I think what we're going to have to do is, consider if Dr. Paling and Dr. Kobayashi are okay with this, is another round of feedback, and we have time to vote tomorrow. I mean, I think our goal is to make sure this is as clear as possible for those who are delivering vaccines. And so again, I take this all as a positive, an improvement in a feedback cycle that will continue to make these recommendations clearer. So Dr. Daly next, and then I'm gonna go to Dr. Long, and then Dr. Lair.
So, I have a couple thoughts. I think one thought is I would second sort of, let's get the language right and then vote on it tomorrow to make sure that it's clear. A second piece is to say that we could take an approach of sort of identifying groups who are recommended for pneumococcal vaccination and then talk about a first dose and then a second dose, because I think sometimes that language will fit. And in this case, the second dose could be PCV 20, so that might work. And then a third suggestion would be that potentially we could put all three of the recommendations as I'm not sure it's a single, here's how we're recommending to change the recommendations, because as Dr. Bell said, changing one actually then may change some of the others too. So that's not exactly a solution, but it's at least a suggestion for a path forward. Thank you.
Thank you. Dr. Long?
Yes, I agree with that approach, Matt. I think we can't get away from the header being those who have received PCV 13 and say that there are several groups here. I mean, you should not have received it if you didn't have some indication, or maybe you got it by mistake, and you could name those groups and what you were meant to do, what the current recommendation is, and what you could substitute. And that would get you to the 1 year for the PPVS 23 or the 8 weeks, I'm sorry. You wanted to do that for the immunocompromised. I mean, you may truly have immunocompromised in there. You don't want to put them all into one bucket because these are all to take those buckets apart I think putting them into one bucket in this kind of is just more confusing than it is helpful.
Okay, let's keep going. Dr. Lair.
Thank you. I've spent a lot of time thinking about this, and my sense is that this is a transitional vote, that there are people who have asked the work group, this patient's got PCV 13, can they get PCV 20? And what we're saying is, yes, if you got your PCV 13, you can get PCV 20, avoid PPSV 23, you're done if you get PCV 20. So that's, in my mind, all this is. It's probably good for a year, and then hopefully no one will fall into this category anymore. I respectfully disagree with Dr. Daly. I would not bump these three policies because the third policy, in my mind, is a very separate policy that requires a totally different discussion. This is a very specific topic of, I got PCV 13, can I get PCV 20? Or can I get PPSV 23? And yes, you can get either one. Whereas before, we didn't allow them to get PCV 20. We're saying, yes, now you can get PCV 20 to finish off. And then in a year, everyone will be finished off and this will be moot. That's my impression of this.
Dr. Cotton, and then I'm actually going to call on Ms. McNally. And actually, since we are not going to vote today, I'm going to, you may turn your cameras off. I did turn mine off while we continue to have this conversation. Dr. Cotton.
Can I ask the working group, what data support this 1 year gap between PCV 13 and 20? And what happens if they're given 3 or 6 months apart?
Yes, thank you, Dr. Cotton. So we did review available, so only immunogenicity study data are available. So the shortest interval that we saw was an interval of 6 months between PCV 13 and PCV 20. And the reason why we settled with at least 1 year is because there is an immunogenicity study of PCV 13 series that showed that after the second dose of PCV 13 given 1 year later, the immunogenicity, immune response was actually lower for some serotypes compared to after the first dose of PCV 13. So there is some concern of some interference of the antibody. So therefore, at least 1 year is something where we thought we might be comfortable with for everybody.
Dr. Paling, did you want to respond?
And to further, part of the goal was to keep this as similar as to the current recommendation, which is that you can get PPSV and try to keep that on the same time frame.
I'm going to go to Ms. McNally, but before I do, I'm just going to ask my colleagues, if you still have a question, please leave your signs up. If not, please turn them over. Ms. McNally.
So I understand the need for this, but it is really complex. And I am concerned about what Dr. Cotton has said regarding implementation. And I am wondering if it's possible prior to a vote tomorrow, if we could see a visual aid that would be prepared for both vaccinators as well as the public to be able to understand this issue. Thank you.
Thank you. You received some nods in the room. We think that would be helpful. We're going to move to Ms. Bata.
Yes, and similar to what Jamie said, I think that we need to, in the language, include those who have previously started a pneumococcal vaccination series with PCV 13 before the new recommendations can finish it with this or this. I think that would be helpful. And the other thing is, the adults age 65 and older, are we supporting now the old recommendation? Because we had removed that recommendation for PCV 13 plus PPSV, and are we reinstating that?
Thank you for this question. So it's an interim recommendation in that the whole purpose of these proposed options are for those who started their series with PCV 13. So yes, we no longer recommend PCV 13 for who are pneumococcal vaccine naive, but we acknowledge that there are some people who were vaccinated based on the previous recommendation. So we're trying to, what we're trying to explore is whether the new higher valent conjugate vaccines can be offered to these people.
Any other questions or feedback? I'm just, for myself, and I thought the COVID-19 pediatric recommendations were confusing, but I have to say pneumococcal adults trumps this. So for me, I think what would be really helpful to me, I understand the recommendation is really to help simplify and clarify that completing a vaccine series with other available products is a very reasonable thing to do. I still find the original recommendations we had made years ago to be confusing. So I think, I just want to clarify, the visual that could accompany this that would help me understand what exactly we're voting on would say something like, if you are a healthy adult 65 and older, you know, here are your options. If you are immunocompromised, here are your options. And if you're chronic medical conditions, here are your options. Or is that more confusing? So my colleagues think that's more confusing, but I find that I need that.
I think that this is Dr. Lair. I think that it should say, if you started under the old rules, you may complete under these new rules. All those other things, this is all related to you started under the old rules. It doesn't matter whether you're immunocompromised or over 65. If you happen to start under the old rules, you may finish under the new rules. That's how I'm interpreting this.
Yeah, I think I'm okay with that language for the vote, just to respond. I would just say I would benefit greatly from a visual that would say, I am a person coming to see my doctor, what do I need? That would help me a lot. Dr. Daly?
Yeah, I mean, I think we're going to need to figure out a way to merge these then, because again, I would go back to the point that I understand that the intent is to complete the series with, but I think if I was either a patient or a provider in the office, I would try to find a 42-year-old with diabetes and then go from there. And then I could factor in whether that individual did or didn't get a PCV13, I think. But again, I'm a little bit concerned about defining somebody by what vaccine they received and then all that implies. I would feel more comfortable with age and condition, but then I don't know if that works, because then you have to say, and also did or didn't get a PCV13. That's the sort of old rules. I think I have a challenge trying to figure out how much you need to know about the old rules to do this right.
Dr. Hahn?
Yeah, thank you. Can you hear me okay?
Sorry, Dr. Hahn, we can't hear you.
You can't. Okay. Hold on. Okay, I switched my mic. Is that better?
Yes, that's better. Please speak directly into the mic, and I think we'll be able to hear you.
Yeah, thank you. Yeah, I just wanted to suggest, I think of all the, I've been on ACIP as a CST liaison for probably 15 years or so, I don't know. I think of all the recommendations, I agree with you. These are so complex and so confusing. Of anything that I've heard of, this would benefit from one of those tools where a patient or the provider could go in and put in age and then be guided through a series of, do they have these or these conditions? Have they received previous vaccine, and which vaccine was it? And then be told, based on all this, this is what they should receive. I think without that, providers are going to continue to be extremely confused about that. So I just want to put in plug for that, if that hasn't been already suggested.
Dr. Long.
Dr. Lee, do you think it would be helpful if we tried to answer the third question? If we answered the third question, and I'm confused if the third question is now part two of the first question, but if we answer the third question, then it seems we could have an overriding principle. Everybody needs to have PCV 20 when they're 65, and people who have not completed their series before that age can complete their series with PCV 20. we might have some overriding principle, but I totally agree with you. You need to have a group that's maybe frequently asked questions or frequently, the answers to certain individuals were certain strangeness, because some of these people, Jamie, are people who, I don't know why nobody knows why they got PCV 13. It might have been a mistake, or they might have wanted it, or they might have, I'm still a little confused what group we grouped with what, because somewhere along the line, it sounded like we grouped sickle cell disease with healthy in some kind of a recommendation. So
let me take that into consideration. Just give me a few minutes to think about it, and I will get back to you. Are there any other comments or questions? Oh, there's more. So let me go to Dr. Bell.
Thank you. Just to to Dr. Long's point, it seems to me, okay, so this recommendation is about people who happen to only have gotten PCV 13, and it's, cleaning up, like Dr. Lair is saying. But the third recommendation to me is actually a relatively big policy issue. Are we going to say that everybody over 65 for whom some sort of pneumococcal vaccine is recommended should all get boosted with a PCV 20? And to me, that's a much bigger issue than how we phrase cleaning up this group, which is an interim group that we don't really know exactly who they are or why they got PCV 13, but there they are, and they're asking if they can get PCV 20. So to me, that's a relative, how to do it is very complicated because these are all very complicated, but I don't think any of us necessarily, it's not as controversial an issue as this question of what do we think about everybody over 65 getting a dose of PCV 20. So I have that as, to me, it's a much bigger question, and the ordering of these recommendations in our discussions, I'm not sure if we're going to end up having to revisit things because we're waiting, in my mind, to address the larger policy issue to the end of the discussion.
Thank you. Dr. Goldman.
No, thank you. Appreciate being called on. I don't know if this helps or further confuses it, but from the primary care perspective, the previous recommendations, the chronic medical conditions would not have received the PCV 13, but as was alluded to, may have happened by accident that they got vaccinated. So in my mind, in some of the discussions we were having in the work group, it's more of kind of a do-over, as was mentioned, that we have PCV 20 now, which has a good immunological response, and that this kind of answers the question that whether you got PCV 13 or not, whether you should or should not have been given it for chronic medical conditions or whichever indication it happened to be given for, move past that, get the PCV 20, and now we can move on to continue the recommendations. I'm surprised that this one is engendering as much discussion as I thought some of the others would have been more controversial. But if that helps simplify from the on-the-ground perspective, what makes it easy for physicians will be whether you got 13 or not, move on, now get 20, and you're covered and you're with the guidelines, and that simplifies it without dividing it further into risk or age. This is just a cleanup for those who happen to get 13 for whatever reason, which they may or may not have been appropriate to have received that previously. Over.
Thank you. Are there any other comments or feedback? So this is my last round because I am going to go to break. So if there's anything else that people want to add or provide feedback on, please do so now. Dr. Talbot.
I also assumed, possibly incorrectly, that if you had received PCV 13 and then had received the polysaccharide vaccine, that you should still be eligible for a higher level of a conjugate vaccine. And I think one of the reasons I'm having trouble with this vote is that anyone who's received PCV 13, regardless of whether they've received PPSV or not, should be eligible for a higher for a new conjugate vaccine.
Thank you. I don't see any additional hands raised at the moment, so I'm going to actually take the opportunity to just state that I think we will plan to reconvene tomorrow with a vote. We will reconsider perhaps the order of the vote, because I think that might make it a little bit clearer if we were to start with vote 3 and then move to 1 and 2. And we'll defer to Dr. Paling and Dr. Kobayashi to lead us through, and we will hopefully be able to come to a cleaner set of recommendations and decisions tomorrow. With that, I'm going to suggest we take a 5-minute break. I'm sorry, colleagues. And we'll meet at, let's see, well, we'll take a 7-minute break, 35 minutes after the hour for our last session on polio. Thank you, everyone. Thank you, everyone. We are now reconvening the ACIP meeting, and we will move on to the session on polio vaccines. Today, I am so pleased to introduce Dr. Kathleen Dooling, who will be speaking to us about poliovirus and vaccination. So, Dr. Dooling, when you're ready, the floor is yours.
Thank you. Today I'll be presenting on poliovirus and polio vaccination on behalf of the newly constituted polio work group of the ACIP. Next. So the objectives of today's presentation are first to review poliovirus, polio vaccination, and polio epidemiology, both in the United States and globally. And second, to review the terms of reference and membership of the ACIP polio work group. Next. So first, poliovirus and polio vaccines. Poliovirus consists of an RNA genome enclosed in a capsid, and there are slightly different capsids that give rise to 3 different serotypes, type 1, type 2, and type 3. Immunity to one of those serotypes doesn't produce significant immunity to the other serotypes. Next. So poliovirus is highly infectious. Person-to-person spread of poliovirus occurs via the fecal-oral or the oral-oral routes. And fecal-oral is the most important transmission pathway in settings with suboptimal hygiene and sanitation. Patients are most infectious in the days immediately before and after onset of symptoms, but viruses may remain present in stool for up to 6 weeks and sometimes even longer. That virus can be shed in individuals with minor symptoms or even no illness at all. Next. So after infection, usually through the oropharynx and potential replication in the small intestine, poliovirus can enter the lymphatic system, and from there enter the blood system in a viremic phase. And from there, it has its adverse effects on the neural system. It can directly damage motor neurons, and if it passes the blood-brain barrier, can cause meningitis. Next step. And it's important to remember that most people who get infected with poliovirus don't have any symptoms at all. 75% of people infected are asymptomatic. Another 25% will have clinical illness, usually diarrhea or other, but no paralysis. And for those that develop paralytic polio, they represent less than 1% of all infections, and that varies slightly by type. So it's important to remember that if one paralytic case of polio is identified, that indicates an outbreak. There could be hundreds or even thousands of people who have been infected. Next slide. So let's move on now to the vaccines that we have to control and mitigate polio infection. First is inactivated polio vaccine. So IPV contains 3 serotypes of the poliovirus that have been chemically killed. So those viruses can't replicate, infect, or cause disease. IPV induces very effective humoral immunity, which means that it is very good at preventing paralysis. About 90% of subjects will receive seroprotection after 2 doses and 99% seroprotection after 3 doses. IPV induces some nasopharyngeal mucosal immunity, but limited intestinal immunity. And so what that means is that people, even who have had full courses of IPV, may still shed poliovirus in their stool if they are infected. And since the year 2000, only IPV has been recommended for use in the United States. Next slide. Now on to oral polio vaccine. So this is a live attenuated vaccine, which contains a live weakened poliovirus. It's given orally, and then it usually replicates in the gut and is shed in the stool. It prevents paralysis and transmission of poliovirus. It's the vaccine of choice in developing countries or countries that are experiencing polio outbreaks. However, if it's allowed to circulate in under-immunized populations for long enough, attenuated viruses can revert to a form that causes paralysis. Next slide. Next on to discuss polio in the United States and global eradication efforts. Next slide. Paralytic polio decreased rapidly in the US after introduction of the polio vaccine, the inactivated polio vaccine in 1955. And then subsequently, the oral polio virus was used in 1961 in the US. Shortly thereafter, the US saw its last wild-type case of poliovirus, and that was in 1979, and by 1994, the Americas were certified polio-free. In 2000, the ACIP voted to only use inactivated polio vaccine going forward. Next slide. So now to look globally, in 1988, the Global Polio Eradication Initiative was established based on a vote at the World Health Assembly. Great progress was made, and by 2015, wild poliovirus type 2 was actually eradicated. In 2016, the Sabin type 2 portion was withdrawn from the oral polio vaccine in a maneuver that was globally known as the switch. By 2019, wild poliovirus type 3 was eradicated, and here we arrive at 2022 with only 2 countries that still have endemic wild type poliovirus, that's type 1. However, numerous vaccine-derived poliovirus outbreaks are being detected. Next slide. This gives a depiction of a WHO world map, where as you can see colored in yellow are Pakistan and Afghanistan that still have endemic transmission of type 1 wild type poliovirus. However, if you look at all the green dots, you can see that there are numerous places that have circulating vaccine-derived poliovirus cases. Next slide. So that brings us to recent history with a case of paralytic polio in New York State in 2022. So the presentation was that an unimmunized, immunocompetent young adult developed fever, neck stiffness, back pain, abdominal pain, and constipation. 3 days later, this person developed lower extremity weakness. And 2 days after the weakness began, the patient presented to an emergency department and was admitted to the hospital with flaccid weakness. And as part of the differential diagnosis, was worked up for acute flaccid myelitis, also known as AFM. Next. So as part of that workup, specimens were submitted, including stool, NP, OP, and CSF. And the stool specimen was positive for enterovirus by PCR. Subsequent sequencing identified a vaccine-derived poliovirus type 2, or a VDPV2. This was confirmed by the CDC polio laboratory, and the sequence indicated that there were 10 nucleotide changes in the region that encodes the viral capsid protein, also known as VP1, compared to the Sabin strain. And this indicates that the virus had been likely circulating for about a year since it was, it's in its original Sabin form. And once again, I'd like to remind people that a single paralytic case implies hundreds and possibly thousands of infections. Next slide. So this is a depiction of the New York wastewater polio testing map, current as of October 11th. And you'll see here the southern part of New York State. In the blue are sewer sheds that have tested positive for poliovirus type 2, ones in fact that are genetically linked to the Rockland case patient. And as you can see, given that there's transmission in multiple locations in New York metropolitan region, and this has persisted over months, this qualifies as a circulating vaccine-derived poliovirus type 2 and has been reported as such. Next slide. So let's take a closer look now at the vaccine coverage of 2 of the affected counties in New York. So this slide really highlights the power of understanding vaccine coverage at the zip code level, which can illuminate heterogeneity even within a county. So as of August 1st, 2022, Rockland County and Orange counties had several zip code areas with less than 70% 3-dose polio vaccine coverage among children 2 years old. You can see those there in the dark red colors. Next slide. New York and the counties affected have worked extremely hard to catch up and vaccinate their populations. And polio vaccine doses administered between July 21st, when the case was first notified in the media, to September 25th, compared to that same period in 2021, polio vaccine uptake amongst children has increased 42% in Rockland County and 29% in Orange County. So still work to be done, but progress is being made. Next slide. And now on to ACIP recommendations for polio vaccination. So routine childhood schedule in the United States consists of 4 IPV doses. Those are routinely given at 2 months, 4 months, between 6 to 18 months, and then a booster dose at 4 to 6 years. Next slide. There are numerous polio-containing vaccine products on the market in the United States. One is an IPV polio-only containing vaccine, and the remainder are combination vaccines, which of course are preferred in most circumstances. Next slide. The safety of IPV vaccine is well proven, with the only contraindications being severe allergic reactions after a previous dose or a vaccine component, precautions including pregnancy or moderate severe acute illness on the day that one would be vaccinated, and local reactions including pain, redness, and swelling appeared in about 3 to 18% of people, and severe reactions are rare. Next slide. So the guidance for polio immunization for adults, this is the current guidance on the CDC website and has been interpreted from the ACIP statement, which dates back all the way to the year 2000. Was the last time it was updated. So to go through those in detail, adults who are unvaccinated or have incomplete vaccination for poliovirus should talk to their doctor about getting vaccinated. Adults at increased risk of exposure to poliovirus may receive 1 lifetime booster dose. And examples of adults who are deemed to be at increased risk of exposure include travelers who are going to countries where there's an increased risk of exposure, laboratory and healthcare workers who handle specimens that might contain polioviruses, healthcare workers or caregivers who have close contact with a person who could be infected with poliovirus, unvaccinated adults whose children will be receiving oral polio vaccine, for example, international adoptees or refugees, and unvaccinated adults living or working in a community where poliovirus is circulating. Next. So there have been a number of innovations in polio vaccination in recent years, and we thought it good to bring those up here, and these will be points of discussion for the polio work group. Next. So novel oral polio virus vaccine type 2 was developed to better respond to the evolving risk of circulating vaccine-derived poliovirus type 2. NOPV is more genetically stable and less likely to be associated with the emergence of circulating vaccine-derived poliovirus. It can provide mucosal immunity to limit the spread, even amongst IPV vaccinated people. And it was approved for use under the WHO emergency use listing in November 2020. Safety data on the first 65 million doses of NOPV that were used for outbreak response was reviewed by the Independent Global Advisory Committee on Vaccine Safety, and they concluded that there were no obvious red flags or safety concerns. And for countries that have eliminated polio and only use IPV, such as the United States, the WHO Strategic Advisory Group of Experts recommends to respond to circulating vaccine-derived poliovirus with routine and catch-up immunization with IPV. That should be continued. And countries should consider use of NOPV if IPV response does not stop the circulating VDPV. For example, if the outbreak spreads beyond a well-defined population group or geographic area, or if transmission persists. Next slide. Another innovation has been the fractional dose IPV. So many countries now are switching to IPV-only schedules. And although the United States has a stable and secure supply of IPV, the global IPV shortage has limited the number of doses available. fractional IPV administered intradermally using 1/5 of the regular dose stretches the limited supplies of IPV. The use of fractional dosing has been recommended by WHO as a response strategy for VDPV2 outbreaks. And currently, fractional doses are not recognized as a dose which satisfies immunization requirements in the United States. Next slide. So at this point, I'd like to turn it over to the workgroup chair, Dr. Oliver Brooks, to lead us through the terms of reference and constitution of the workgroup.
Thank you, Dr. Dooling. So since this outbreak occurred in New York, it was determined that we need to revisit polio. I guess it's really that simple. And so we have, as a work group, have met once only, and we're looking to the ACIP as a whole to look at the terms of reference that we have determined and offer any suggestions or comments regarding this. So we have these four. So whether more specific guidance on adult vaccination, which was addressed in the presentation, I believe that goes back 20 years, so it hasn't been addressed in a while, including the use of adult booster doses can be provided in the context of circulating poliovirus, which we now see. Whether adults who are immunocompromised should be recommended an additional adult booster dose of a polio-containing vaccine, whether we use fractional, which you see the WHO said, but we do not, as pre-qualified by WHO, should meet polio vaccination requirements, including for people immigrating to the U.S., and consider criteria under which novel oral polio vaccine might be used in areas with outbreaks or persistent circulation of poliovirus. So, like I said, we've met once. And this is where we are with our terms of reference. Next slide. So I just want to recognize, first of all, Kathleen and the CDC for convening this work group, and my other partner here, who is an ACIP voting member, Lynn Bada, who does have experience with polio. Lynn, I don't know if you want to make any comments before we just open up the floor to any recommendations or discussion.
No, I have no comments right now.
Thank you. So go back one slide, please. So that's where we are right now. So any, I guess I'll turn it back over to Grace. So any comments, though, that anyone may have regarding this, because we're right at the very beginning of this work group.
Any questions or feedback? Dr. Cotton.
Thanks. This has engendered a lot of questions in my workplace. I was wondering, so for the ACIP polio immunization recommendations for adults, adults who are unvaccinated or have incomplete vaccination for polio should talk to their doctor about getting vaccinated. And people are asking me, they say, well, I'm seeing a 70-year-old person who doesn't have their vaccine records. Do I need to vaccinate them? So what is the guidance in that context where they were born and brought up in the United States, they went to schools in the United States? What do you say there? Because I'm worried that a lot of people are actually maybe giving polio vaccine, and I'm worried about supply and whether that's appropriate use. And then I also have a question about immunocompromised as well.
Hello. My name is Janelle Ruth, and I am the team lead for the acute flaccid myelitis and domestic polio team. I think it's an excellent question, and we've been getting a lot of public inquiries as well about older adults who have lost their vaccination records, can't remember whether they were vaccinated. I think, you know, in general, we say unless there are specific reasons to believe an adult was not vaccinated as a child, adults who were born and raised in the United States likely did have polio vaccine as a child, you know, given the fact that vaccination started back in the late 1950s and early 1960s. It's most reasonable to expect that they were vaccinated. Large campaigns were made to get all school children vaccinated, and so we're really trying to have a conversation with those folks about how how they are most likely to be vaccinated, even those vaccination records aren't available. I think if somebody is particularly concerned or again might live or work in an area where poliovirus is circulating, I think the safety of IPV suggests that they could go ahead and get an additional booster, but at this time we are not recommending it widely.
Thank you. Dr. Sanchez?
So I have a few comments or a few questions. First of all, was the water testing, did that occur at the time that this patient was diagnosed, or do we have data from before and in other communities because I mean, there's people who visit the United States all the time who come here and live here who have had poliovirus, oral poliovirus. So they're going to be shedding it. And so do we have that data, first of all? Okay.
So Dr. Sanchez, thank you. We have been following the global guidance, which suggests that environmental surveillance for poliovirus is best done in connection to a case. So we're not recommending at this point widespread wastewater surveillance, but we have been conducting rigorous wastewater surveillance around the case patient in New York State, both retrospectively, so looking back previously from the date of paralysis onset, and then moving forward. We have found detections of poliovirus linked to the case patient earlier, so prior to the paralysis onset in the months of May and April, and we are continuing to find detections of this poliovirus linked to the case patient's virus moving forward in subsequent months, August and September.
But you don't have that data then from other areas like, let's say, Boston or California or wherever?
So again, we've really focused on looking at communities that might have contact with the New York State community. And so we have done additional wastewater testing in New Jersey and Connecticut. But all of those specimens to date have been negative. Now, I'll say that in New Jersey, we didn't test specifically in the county where we might find communities that have ties back to the New York State community, but are moving forward to look at that. Again, in other states that border New York, we have not moved forward to do additional wastewater testing at this time.
And this was a type 2, right? But type 2 was removed from the oral polio vaccine. So
where's it coming from?
Yeah.
So you're right. Now for routine immunization, bivalent OPV is being used, which contains only types 1 and 3. And as Dr. Dooling alluded to, that switch was made in 2016. However, because of the ongoing circulating vaccine-derived poliovirus outbreaks, the response to those outbreaks has to be with oral polio vaccine type 2. And so in previous years, they've been using a monovalent oral polio vaccine type 2. And that monovalent, it's sort of this chicken and egg cycle where the monovalent OPV, when given to prevent subsequent spread of the outbreak in under-vaccinated communities, can circulate and seed new VDPV2 outbreaks. I think that's changing with the novel OPV2 coming on board. Over 500 million doses, I think, have now been given worldwide. And so I think we're all hoping with the lower rate of stability of this virus, so it doesn't revert back to neurovirulence quite as often, almost never, we'll start to see a decrease in those outbreaks moving forward. But that is where it's coming from.
Thank you. Dr. Shaw.
Just a few quick observations. As Dr. Romero and Janelle and others are well aware, this has been a very frequent topic of conversation among state health officials. Janelle has been with us on numerous occasions to walk us through this. One observation on the communications front, Given the complexity of poliovirus, particularly with terms like vaccine-derived, there is this notion out there that polio just happens sometimes, or indeed it is perhaps tethered to vaccination, when in fact we should all be very clear in our communications that the occurrence of polio right now in Rockland County and elsewhere is directly related to the under-vaccination. And that fact is sometimes gets lost, and just underscoring that for everyone as we're all communicating. There are certainly outstanding questions out there around the pros and cons of greater use of wastewater testing. I know that's not in the purview of the working group, which takes me to my last observation for Dr. Brooks and Ms. Bata, which is a frequent question that's come up among state health officials, is the why not switch to the novel OPV, given the mucosal benefits of it. And so we look forward to reading and discussing what the working group comes up with there. Thank you.
Thank you. Dr. Talbot?
Yeah, I think this goes back to the question about the older adults in the United States. I live in a pocket of the U.S. where there was a lot of disparity in healthcare, and there still is a lot of disparity. And tetanus is one of those things where we have cases of older Black women who get tetanus because they were never vaccinated, but their male counterparts were because they were expected to serve in the military or served in the military. And so do we have data on polio vaccination in non-white groups to give us some idea about that population? But as in older adults, not current.
So, you know, I know we do look at vaccination by race and ethnicity in children, and doses that are reported into the immunization information systems across the different jurisdictions. I don't actually know whether we capture that information for adults.
And also, you're referencing adults who are, you know, let's say 50s, 60s, 70s, whatever. My guess, without knowing, is that race and ethnicity was not collected 30 years ago on vaccine administration in adults.
Thank you. Dr. Lear? Yes, Dr. Romero.
So I think it's also important to keep in mind the epidemiology of the disease, wild-type disease, right, prior to the vaccination period. And that is prior to vaccinating the United States in general, prior to 1955, because that's when the vaccine was introduced, and we worked with IPV at that time, right? Prior to that, this was a widely circulating virus, right? And most individuals were exposed during childhood. And most individuals of that age group probably have natural immunity to wild-type poliovirus. You know, they were boosted with the vaccine. So the older individuals probably have natural immunity that exists. Now, that we can get those numbers specifically, I don't think we can get them for you, but we will look.
Thank you. Dr. Daly.
Yeah, thanks so much. I have two questions that are sort of geared towards the medium to long term, but how does what we decide as a committee fit into the global strategy? And I guess I ask that in the context of use of oral polio outside the U.S. and risk of importation here, you know, that kind of thing. And then I have a second question.
It's a great question with regards to how this fits into the global strategy. I think we have been talking to our global immunization colleagues about that very question. And I think you know, the question for them is, what does eradication actually mean now in the context of these ongoing circulating VDPV outbreaks? Now that we've found it in the United States, does eradication mean no paralysis versus actually eliminating the virus from the environment across the world? And so I think it's something good to consider as we move forward with these NOPV discussions in the United States. I think it's going to be an important factor to understand how they're viewing eradication, and that probably will lend itself to how we might think about using it here.
And then my other question is, what's our metric of success in terms of our management of this as an outbreak? And is it, I mean, I don't know enough about the circulation through wastewater and then as it relates to cases, because clearly an unvaccinated 20-year-old is clearly at risk, but does success, I mean, part of success is no more cases of paralysis for sure. And then vaccination should lead to that, but does vaccination also then lead to decreased circulating in the sewer water, and over what time frame? So kind of what are our metrics as an immunization program for success as we make policy decisions about vaccination?
So those are all really good questions. Again, questions that we have been talking about internally on the response. I think you're absolutely right. Success means no more cases of paralysis, but I think it also means elimination of the circulating virus in wastewater, because as long as we have wastewater detections of this circulating virus linked back to the case patient's virus, we know there is ongoing transmission in the community, even without paralysis. So, we can talk certainly about the dynamics of transmission. I think in the United States, which for the most part, we have good sanitation and hygiene. Transmission of poliovirus is more oral than it is fecal-oral. We do know that IPV provides some nasopharyngeal mucosal immunity. And so certainly recent global deliberations have said that they do recommend continued IPV use for outbreak response in countries that only use IPV in their routine immunizations. And so we are certainly following that guidance right now. As Dr. Dooling alluded to, if we start to see this virus break out of its current geography and population, I think then we need to start thinking about other methods. But to me, the metric of seeing this outbreak end is seeing no more virus detections in wastewater, and that will take time. Globally, again, they recommend testing for an additional 6 months after the last positive detection in wastewater, and so currently we have a ways to go.
Thank you, Dr. Romero.
So I think a comment is worthwhile here based on what has been said and what Dr. Sanchez said. So we are a global society, right? People move very quickly from parts of the world which use vaccine, oral polio vaccine, and bring it in. So I think it's important to keep in mind that we have that to say that something is broken out of its environment, right, where we see it now, really requires genomic sequencing and understanding this, because finding the virus, for example, I will use just a city. It doesn't mean that they're at risk or not, but let's say Chicago, right? Because Chicago is a travel hub, right? That doesn't mean that it came from New York. And so that in itself does not mean that there's a spread or breaking out of the virus. It's very important that we understand that, and the public has to understand that also, that our ability to surveil, right, for this virus currently outstrips our ability to understand really how this virus is traveling around the world. So I think that's an important issue to keep in mind.
Thank you, Dr. Long.
I'm sure, I'm going to wait till she's.
Let me just clarify too. Dr. Sanchez, do you have your hand raised?
I do
No?
have a question,
Okay.
but he's talking to the questioner.
Yeah.
I don't know her name. What's her name?
Dr. Long.
Yes, I have a question for you. So with the enormous increase in the number of clinical detections of enterovirus, rhinovirus, that now, the BioFire identifies together and doesn't separate. I'm wondering if you're looking at some of those at CDC for lesser diseases than acute flaccid paralysis to know if we do have any circulating strains in the United States. Or do you only look when you have acute flaccid paralysis? Because for us clinicians, an enterovirus is an enterovirus and a poliovirus is an enterovirus, and that's all we'd hear, and we don't look unless there's something special.